لأماتي وخالاتي وعماتي وأخواتي وصديقاتي وزميلاتي كل الأهل بالسودان، وبرجع وبذكركم تاني إهدائي لكم وبقول لكم قبل الألم والشعور بالندم تعالي أفحصي واشكري النعم. تعالي أفحصي، أبعد القلق والألم النفسي، اطمني عيشي حياتك وانتعشي عشان تتخلصي من المرض، ما تنتظري ظهور العرض. سارعي احجزي للماموجرام، احمي نفسك وافحصي الآن لتنعمي بالأمان قبل لا يفوت الأوان. احمي نفسك، سارعي وافحصي الآن للكشف المبكر عن سرطان الثدي. This is full digital mammography system including 3D tomosynthesis. So all together, join the fight and show support for breast cancer awareness, not only in October, but throughout the year. Again, just reminder, what are mammographic features of breast cancer?
Either a definite mass or architectural distortion or asymmetry between the two breasts, or could be developing asymmetry, microcalcification or skin thickening or nipple retraction or lymphadenopathy.
Okay, nice. So it could be a mass, it could be asymmetry, it could be microcalcifications, architectural distortions, nipple changes, axillary enlargement, or skin changes. All these can be presenting features, mammographic features of breast cancer. Okay, so today we are going to discuss and to go through the systemic approach to evaluate mammographic masses. Are you ready? You will see this illustration throughout my lecture. It is essential that the radiologist evaluating a mass differentiate those are characteristically benign from the indeterminate or suspicious lesions. So the BI-RADS system determines standard lexicon to be used by radiologists when studying each findings. The breast imaging reporting and data system was developed in part to improve the predictive capability of mammography. With the latest version is the 5th edition of the ACR BI-RADS Atlas 2013. The description of masses in mammography is based on BI-RADS system provided by the American College of Radiology. The ability of mass descriptors to be used to help stratify the risk of malignancy has important clinical implications. And identifying important descriptors could help radiologists improve the predictive value of biopsy. Again, mammographic abnormality, breast imaging lexicons provide an organized approach, image interpretation and reporting, and is strongly recommended to be used. So what are the mammographic abnormality included in the breast imaging lexicons? Is a mass, asymmetries, calcifications, architectural distortions, intramammary lymph node, which is rarely important, skin lesions, rarely important, solitary duct, and then the associated features for these main abnormalities and the locations of the lesions. So today we are going to start with masses. Huh? Can you see any abnormality in this mammogram or is a normal one? Any volunteer? Anyone who would like to participate?
Maybe in the medial part of the breast, there is a mass.
Okay, describe a mass.
The middle, regarding the depth in the middle part, the mass is irregular and is isodense to the breast tissue.
Okay. Do you mean this area?
Yes.
Okay. Do you think this is the only abnormality? Or this is part of which? I would like you a little bit concentrate more. In the same area you are in the same area of concern.
Yes.
Yes. You got it?
It is larger. Yes, it is.
Huh?
But I have yes, where you are exactly containing different
okay.
Constituents or different components.
Okay, contain different components. And what about this mammogram? Any volunteer? No abnormality? Is it normal mammography? Is this a normal mammography?
No, it seems not.
Demonstrate what?
In the lateral aspect, again, there is a mass in the lateral aspect of the breast.
Okay. You said there is a mass. Here there is a mass, and here there is a mass. Abir Al-Hadi.
Yes.
Okay.
Assalamu alaikum warahmatullah.
Wa alaikum assalam. Tell me why she said there is a mass. Why she said this is a mass and this is a mass. What do you know about a mass?
Mary said that this is a focal asymmetry.
Focal asymmetry, the asymmetry different from the mass. See, that is why. Did you start from the beginning? You attend from the beginning?
I have logged in, but I have some technical issue regarding the voice. I couldn't hear you,
okay.
But now,
okay.
Shortly, yes.
Okay, what are the mammographic abnormalities? Described by the ACR lexicon. What the ACR lexicon? Mammographic abnormalities. What do you expect to
focal
find?
Asymmetry, could be architectural distortion.
Okay. Asymmetry, architectural distortion. Okay. What else?
Skin thickening.
Okay. We have major, and then we have minors. So we have 4 major abnormalities. What are these 4 major abnormalities?
Mass.
Mass, excellent.
Calcifications.
Calcifications, excellent.
ductal dilatation.
This is a minor. This is not a major.
Okay. Okay.
Not commonly seen.
Maybe lymph node, lymphadenopathy.
Huh? Okay. So can you see it here?
Yeah. Mass asymmetries, calcifications, architectural distortion.
These are the four majors. And then
intramammary lymph node.
Rarely important.
Yes.
Lesion, rarely important. Solitary duct, rarely present. Associated features. This is like skin thickening, trabecular thickening, and so on. Then location of the lesion. So our main abnormality or abnormal findings are the mass, asymmetry, calcifications, and architectural distortion. So when they
ممكن تسخني لي من اللبن ده شوية؟ تسخني لي من اللبن ده شوية.
May you close your microphone, please? Would you close the microphone? Close your microphone except for Abir. She's discussing. Please. Abir?
Yeah,
hello?
welcome, doctor. Yeah.
Okay. Okay. So that means you have mass and you have asymmetry. So there is definitely difference between mass and asymmetry. And since I asked you to describe, this is a mass. Describe the one on the left and the one on the right mammogram as a mass. You describe this as mixed density mass, and this is opaque mass. So I'm asking you why she said these are masses. Do you know?
Maybe because they are, I don't know actually,
I
but
don't
maybe
like, yeah, I'm not expecting you to say this is a focal asymmetry, because when you talk about asymmetry, so you have to discriminate it from the mass. You have to say this is a mass, no, this is asymmetry. Because of these reasons, this is an asymmetry. And because of that reasons, this is a mass. Do you know?
well defined. Well defined. The masses are well defined.
All the masses are well defined?
No, but more defined than the asymmetry.
You mean more discernible? Okay, okay, is a more discernible, yeah. What does it mean? You are right. It is a more discernible than an asymmetry. That means, it means what? Any volunteer, he knows the difference. He knows what is the mass.
And regarding the density, they are more dense than the asymmetry.
I think the mass has an outline.
Hello.
Hi.
You're welcome.
Thank you. I think the mass has an outline more than the asymmetry.
The same, more discrete, more discernible.
Yeah.
More discrete, more discernible. Okay.
Yes.
What else?
Can we say that it occupies a certain space?
Yes. This is the definition of the mass is occupying space. Is a three-dimensional occupying space. This is when, what else? So this is a mass. Agree. These are masses. So what is the mass? We said a three-dimensional lesions occupying space, or is an space occupying lesions having a three-dimensional dimensions. Okay? That is what you are describing, the same as you are describing when you are saying a discernible or a discrete or like that. Yes, it is. That means, so we expect to, since it is three-dimensional lesions occupying space, we expect to
see it in two views.
to see it into different or into the different mammographic projections. So what else?
Mass effect like compressing the adjacent tissues.
Excellent. Yes, the mass effect is occupying space. Yes, characteristic by its shape and contour. You see, it has a shape and contour or margin, not necessarily to be well defined or circumscribed, but at the end it has a margins, it has a shape, it has a morphology. That means characterized by morphology. The mass has a morphology, unlike asymmetry. So it has a consistent shape, okay, on different projections. What does it mean? Not necessarily the same shape, but at the end, it persistently having a shape. When you look at it in CC or MLO, you will find the mass having a shape and have a convex outward borders. It has to have a convex out at least partially. Without convex border, you cannot say this is the mass. See? Unlike the asymmetry, it has no convex border. It is usually concave or something like that. It doesn't have a convex outward borders. And the other difference between the mass and asymmetry is that the mass at the center is radio opaque. It is denser at the center of the mass. Okay, while the asymmetry, at the center is less density. The density is less at the center, less radio opaque or less radio dense at the center. But the mass at the center is more radio opaque. And if a potential mass is seen only on a single projections, we should describe it as asymmetry until it's proven or it's confirmed to be a mass. Because sometimes an asymmetry, a mass appear as asymmetry, but because obscured by super added press tissue, when we do compressions or do other view, we might find the other criteria of that confirm the lesion to be, or the added density or the asymmetry to be a real mass. Okay? Is it clear? Clear for all of you?
Yes.
Yes.
Okay. So our talk today, it will be regarding the mass and the descriptors of the mass. Evaluation of the mass on mammography to discriminate benign versus malignant lesions. So the approach, the systemic approach to masses according to the BI-RADS system is, do you know how we could characterize the mass according to the BI-RADS?
By its shape, by its margins, and by its density.
Excellent, well done. Any more? You are right, 100%. These are
Any
the most
associated
important.
features with it?
What?
Any associated features with it?
Excellent, excellent, well done. What else? Okay, these are the most important. So if you have a mass, you have to describe also. When you describe, these are discriminating factors, but you have, for any mass, you have to tell about it is
Location.
excellent. You have to tell about its location. Where is that mass? Okay, what else?
Size of the mass.
Excellent, well done. The size of the mass. So these are the criteria or the descriptors of the mass according to the ACR. The most important is morphology, including shape and margin, the density, size, locations, and associated features. Okay? Any volunteer that can describe for me this mass? Now we agree, all we agree that this is a mass. Now we know, we know how to characterize the mass. Okay, we know the descriptor for the mass. We have certain descriptors. Just follow these descriptors and tell me what you know about this mass. Anything I will accept.
Yes, in this craniocaudal view, the mass appears to be in the lateral side.
Abir,
Yes.
you're welcome, huh?
Yes.
You said,
There is a semi-rounded mass in the lateral
Why
part.
you said semi-rounded? This is the question. Why you said semi-round?
The outer margin of this mass is obscured by the
So
a little bit obscured by the breast tissue.
Yes, this is regarding the margins, but doesn't affect the shape.
Okay.
Okay.
Rounded
when you
mass.
So rounded regarding the shape is rounded. Excellent. Okay. Regarding the margin.
Slightly irregular margins.
Why you said irregular? At the beginning, you start correctly. You describe
I have
part of the lesion obscured by, and then return back to irregular. Why?
No. Okay, I have zoomed the image. It's regular margins. Part of it obscured by the underlying breast parenchyma.
So you describe it as, you know the margin.
With regular margin.
Rounded. This is regarding the shape. So it has a regular shape. Okay. Margin. What about the margins? You said partially obscured. When we said partially obscured, there is one word before partially obscured. What about the rest of the margins? Here is there is even
regular outline.
Thin halo. The outline, we are saying what? Describe it as what?
Circumscribe.
Circumscribe. Excellent. Who described who mentioned the descriptor?
Me, Medina.
Welcome, Medina. Yes. Circumscribe, partially obscured, rounded. Okay, mass. This is regarding morphology. What else?
It is isodense to the breast parenchyma.
Excellent, well done. It is isodense. The isodense is historical descriptor in the previous edition. The latest edition, the descriptor is changed to, do you know?
No, I didn't know.
Same as ISO. ISO, that means, what is the meaning of ISO? If I told you,
Same.
what does it mean when you said ISO to parenchyma?
Near same to the parenchyma.
Okay, it means equal, yeah?
Equal, yeah.
So now equal density. The new descriptor is equal density. Excellent, well done. Type, what else?
You have to mention the size also.
Excellent, well done. How you mention the size? How you do you measure the size?
I think there is a ruler in centimeters or millimeters.
How
Two-dimensional.
how do you measure it? How do you measure the lesion? Tell me, describe, how do you measure it?
In most of the radiographs, there is an added measurement in the periphery of the film.
Okay.
So I could use it to measure the mass.
Yes, how you will measure it? Yes, still you have a ruler now.
In 3 dimensions, I could measure it in 3 dimensions through the 2 views, the craniocaudal and MLO.
Now we have only one view. In this view, how you will, you are going to measure? How you will measure it?
I will measure the AB dimension and the transverse one.
Okay, if it is obliquely oriented and it is oval, again, you will measure it like that.
No, I will measure the diameter.
You will measure what?
The diameter.
Which diameter? You are right. Which one?
The longest diameter of the mass.
Excellent,
If it is oval.
excellent, excellent. You are going to measure the maximum dimensions or the longest diameter of the mass, and this is 1 dimension. Regarding the other one, it will be okay, if you measure the longest or the maximum
I will measure the other dimension on the orthogonal view for that.
Orthogonal view or the same view?
Sorry, orthogonal dimension in the same image.
Excellent. Orthogonal, it will be perpendicular to the other, with that dimensions. Excellent, well done. Well done. Okay, where is that lesions? If you are telling me by phone and you are describing that lesions in an excellent way, but I don't know where is the lesions.
It is in the middle. It is in the middle of, sorry, it's in the lateral side and in the middle parenchyma of the breast.
Again. Again.
It's in the middle part of the breast parenchyma and more to the lateral.
Okay, so it is in outer breast. Okay, I don't know if it is upper or lower, but it is outer because I have only a CC view, and it is more toward anterior rather than the middle depth. If you, when you are talking about the depth, you might make it like that,
Yeah.
you see, and divide it. This is the posterior, this is the middle, this is the anterior. It is more toward the anterior. And you can measure the distance from the nipple, and you can make if we draw a line here, it will be which clock? If I draw a line from the nipple to the back, it will be?
It will be 6 and 12.
Excellent, well done. It will be 6 and 12. Then this is right, yeah? This is right breast. You did not mention it's right. It's very important. It is right breast. So when I go lateral, from 12 o'clock, it will be then
11 and 7.
11 and 7. And then
It will be 10 and 8.
yes. So this lesion either at
10 or 8.
10 or 8 o'clock. Excellent. Well done. Finish. So you have done the whole descriptor in this case. Okay. Just let us revise together this descriptor. Someone his microphone is working, is open, and there is background noise. There is background noise, please. Would you close your microphone? Okay.
Can we all mute our mics? Everyone, can we mute our mics all, please?
Could you mute them, or is it difficult for you to mute them?
اوكي دكتور رباب can you please
أيوة.
اوكي ايوه اوكي كده تمام.
اوكي.
معلش يا دكتوره سوري تو
أيوة.
انتربت بس الكويستشن بتاع الميجرمنت كان وي بعد ما ننتهي نعمل ريكاب بس سريع لانه I didn't quote it clearly عشان الريكوردينج.
Revise. Okay, we are going to we'll describe it again. Okay.
Okay.
Let us continue according to the BI-RADS system. Okay. The descriptors, as we mentioned, will be morphology, space and margin, density, size, location, associated features. So the highlighted is morphology. We are going to start by morphology as you described. Okay. Again, what are the shapes of the mass? What do you know about the shapes of the mammographic masses? You described before round in the previous examples.
Oval.
Oval, okay, excellent. Rounded oval and try to remember, imagine mammography in front of you, a lot of cases, you will find shapes of round, oval, and if it is neoplastic process, if it is malignancy, the shape you expect will be
Indistinct.
indistinct is a margins, is not shape. We are talking about the shape. Okay. Speculated is margins also. So the shapes, it will be round, oval, or irregular. Okay? Either regular, rounded, oval. If it is regular, it will be rounded or oval. If it is irregular, this is the other type of shape. The shape of a mass, either irregular shape or regular shape. If it is regular shape, it will be round or oval when it is regular. It's okay. No more lobulated shape. In the previous, there was a descriptor of a lobulated shape. Do you have this cross? No more descriptor lobulated shape. Okay. So what is the shape of this?
Oval shape.
Oval. Excellent. What is oval? Oval shape is an elliptical or egg shape. Okay. It can include 2 or 3 large undulations. So the previously described as lobulated shape now is described as oval shape. Okay. What is the shape here? How you describe this shape?
Irregular.
Why you said irregular?
Oval. I can see some lobulations. I don't know on the left image.
You can see some lobulations, but how does it look? These lobulations. Just we describe
Oval. As oval.
Oval. We said oval.
2 or 3 undulations.
2 or 3 undulations. If you have 2, even here, even for this, our case, you see, this is our patients having a circumscribed lesion completely surrounding by fat, and it was having an oval shape. It was a fibroadenoma, the outcome. And these lesions is so circumscribed and oval, you see. And we describe here, there is one, this is not throughout symmetrical. There is some undulations here. But if there is 1, 2, 3 undulations, then we'll describe it as an oval. Okay, no more lobular shape. Previously being described as lobular shape. Now there is no lobular shape in the latest edition of descriptors. You see, if you have gentle or large 2 or 3 lobulations or undulations, we'll describe it as an oval shape. And what is the shape here? Now, Allah, we want you to go quickly. We spent long time.
Round shape.
Round shape.
Rounded.
Yes, round shape is spherical, ball shape, circular, or globular. You see? And this is surrounding by thin halo. And as this is also partially surrounded by thin halo. So both are circumscribed, rounded masses on mammography, while this on ultrasound was fibroadenoma, or in core biopsy, ultrasound core biopsy, it was fibroadenoma, and this on the ultrasound was a simple cyst. Okay. What is the shape for these 2 examples? case 1 and case 2. Huh? Yalla, let us go quickly. We'd like to see to complete the whole lectures within these 2 hours. What is this shape? The shape of this?
Here there are multiple masses, 3
Is it-
masses.
Is it an oval? Is it rounded?
Rounded. But is it more than one mass, doctor?
It is, these are interconnecting, forming a single mass. So, what is the shape of this mass?
I think oval also.
Even if you said this is different, this is part of which? See, this is part of the mass.
So it's irregular.
It's irregular. This is irregular. And what about this one?
It is oval.
Oval.
Okay. What about the margins?
Obscured.
So you need
Speculating. Speculating.
you need, what is next? What is next? You need to do what?
Ultrasound.
Before ultrasound.
Compression
the-
magnification view.
Excellent. What is the shape of this mass? Now, after compression, what is the shape?
Irregular.
It's irregular. You see, sometimes we need to do magnification, compression, compression, or with or without magnification to further characterize the morphology, shape or margin of a mass. So this is an irregular, neither round nor oval shape, and usually implies suspicious findings. The outcome in this case, this is our patients, it was invasive cancer. Both are my cases were invasive cancer. And the positive predictive value of this shape is 73. So it will be Bharat.
4.
For what?
4C.
Excellent. It is a 4C. So if you have a lesion having an irregular shape, not associated with any other, just you have an irregular shape, then you will describe it as 4C. It might tend to be benign or malignant, but it will be 4C. So this is a 4C. And the oval shape, the oval, and we forget to mention the pirates. If the lesion is regular, is having oval or rounded, then it will be the positive value. It will be
3.
3. Bara 3. Yes, excellent. It will be Bara 3 because we mentioned here these 2 lesions. I will say these are Bara 3. When I go further and I have done ultrasound, one is downgraded to cyst, Bara 2. You see, one is still probably benign, like fibroadenoma, and for any reason, core biopsy done and proven to be a fibroadenoma. So the result is concordant. Okay, but for this it is BIRAT 4C. Okay, yeah. And what about these lesions? What is the shape of this lesion?
Irregular.
Why it is irregular?
It's not round, it's not oval.
Yes, though it seems as if it has 3 lobules, but the margins are not well shown. It seems to be completely obscure, so that is make it irregular. Despite this mass may have only 3 undulations suggesting oval shape, it is primarily obscured. It is a mask lesions. The mask lesion is also BIRAT 4C, I think. 4B. It's a 4B. Okay. 4B, I don't remember only. 4B or 4C, the mask. What are the margins? So we talk here, we start to talk about the margins. What are the margins expected you will find or related to the mass in mammography? If you have multiple mammography in front of you and you have different masses, so you expect to find
either circumscribed or obscured or
circumscribed, obscured,
indistinct,
indistinct,
speculated,
excellent,
microlobulated,
excellent, well done. So, what does it mean when we talk about the margins? Let us understand, basically, what does it mean, these descriptors, so we could not forget it easy. So what is the margins? When we talk about the margins, we said this.
The most outer part of the lesion.
Okay, so
for this,
the outer outlines.
Excellent. What does it mean by outlines? Yes, the contour or outlines. What does it mean? If I'll tell you something. If the margins not indistinct, but the whole here, the surrounding area is opaque, and this is opaque, all is opaque, and I could not differentiate it from the surrounding. So
there is microinfiltration of the surrounding tissues. This is a feature of malignancy.
So the margins, it means what? Means when I'm talking about the margins of a lesion.
Contrast between the mass and the surrounding.
Excellent, Medina. Yes, the edge or border of a lesion characterization of edge, it means transition between a mass and the surrounding normal fatty tissue. You see? So is it sharp? Is it abrupt? Or is it there is something obscuring or masking, whatever, due to adjacent parenchyma or due to infiltration of the mass itself? See? Otherwise, it will be sharp, it will be circumscribed. You got it? That if you look here, they make it as redudense or bright, okay, oval structures here, and the surrounding is black. The margins, you compare the lesion itself to the adjacent fatty tissue. When you could see sharp margins or the margins here obscured by adjacent parenchyma, however, this adjacent to the fat, very clear, or the margins infiltrating or undulating here, or speculating or becoming distinct due to surrounding reactions or surrounding infiltrations or whatever. You see, this is the meaning of margins when we talk about the margins, so as not to mix in this terminology between the shapes and margins. This is the meaning of the margins. So margins, like the shape, descriptor shape, is an important predictor in differentiating malignant versus benign lesions. So what are probably benign margins? What do you expect from these to be from these margins? So when we are talking about margins, we have five. We have five. The shape, we have three shapes only. Three shapes. The irregular, or when it is regular, either oval or rounded. That is it. No more descriptors. Margins are five. Circumscribed, obscured, microlobulated, indistinct, speculated. So what do you expect to be a probably benign from these?
Circumscribed or obscured?
Circumscribed.
Excellent. Circumscribed and obscured are probably benign. So what is the circumscribed from the definition we have mentioned before? What is the meaning of circumscribed?
A clear demarcation between the mass and the surrounding fatty tissue of the breast. Clear outlines.
Clear outline or abrupt, sharply demarcated or abrupt transition between the lesion and the surrounding fatty tissue. If not associated with calcification, okay, then the predictive value of benign is 98 to 99. So it is BI-RAT
3.
BI-RAT 3. It is a BI-RAT 3, less than 2%. So probability of malignancy, it is BI-RAT 3. And partially obscured. But is circumscribed, partially obscured. That means indeterminate, need further views. For mammography, if part of the mass is seen circumscribed, as we described the circumscribed, you see, sharp like this, abrupt transition, sharply demarcated. Part is sharply demarcated, while part of which is obscured by the adjacent parenchyma. We'll talk about this part of masking or obscured part in more details. And for this probably benign, we have 1.4% of these circumscribed masses to be malignant. We have to put this in our mind. So not 100% is benign. Not all circumscribed are benign. Still, we have probability, but it is only 1.4%, okay, to be malignant. What are the suspicious margins?
The indistinct.
Indistinct?
Yes, and the microlobular.
Microlobulated, indistinct, and
Speculated.
speculated. So for the suspicious, there is tendency of invasive cancer infiltrating into the adjacent tissue, adjacent fatty tissue, that result in indistinct margins. Historically, it was ill-defined. No more ill-defined. Descriptor. Don't describe as ill-defined lesion. Describe as indistinct lesions. You see? And microlobulated and speculated. So, okay, we'll go through all of these one by one. So, what is the margin here?
Circumscribed.
This is circumscribed margin, and as we describe it, is probably benign. It's BI-RAT 3. Historically, was well defined or sharply defined. Before, they describe the lesion as sharply demarcated, sharply defined lesion, well-defined lesion. In the new descriptor, in the new editions, the descriptor, instead of all of well-defined, sharply defined, and this, just a circumscribed. circumscribed mass. See? It means sharp demarcations with abrupt transitions between the lesions and the surrounding fatty tissue, and completely surrounded by fatty tissue. See? If not associated with calcification, we said it is probably benign with positive predictive value between 98 to 99. So the malignant risk is less than 2%. It's okay. So what about this? You have seen these lesions. May you describe it without looking to the what is written below the image? Be honest. Just describe it without looking for the description.
So it's an oval, circumscribed, equal density mass in the upper posterior third of the breast.
Okay. Okay, yes. What our concern is the morphology regarding the shape and margins. The shape is oval, the margin is circumscribed. So because it is completely surrounded by fatty tissue. And this our patients and was stable for about 3 years on mammography and presumptive diagnosis fibroadenoma. Compare with this one. What is the margin here? It seemed to be as if it is oval, but what about the margins? Indistinct margins. Please compare the circumscribed with indistinct. Okay? Though it is at the contour, at the fat glandular interface here. So anterior to which supposed to be fat. If we said obscured by the parenchyma here it's supposed to be fat. In spite of that, the margin. And this patient, I remember she was young, she was 20 plus lady having an invasive cancer, high grade invasive ductal carcinoma. I remember her. Okay, so we describe that regarding circumscribed. We have small percentage. Sorry. Okay. We have a small percent, okay, of this group to present malignant features or malignant mass. What are the differential diagnoses?
It could be, a fibroid, fibroadenoma, it could be a fibroadenoma. It could be a cyst.
Now we are talking about malignant differential diagnosis, about the 1.4.
Malignant. Okay.
Okay. The malignant. If I'll tell you this is a malignant mass, it is circumscribed but malignant mass, so it is within the 1.4%. What are the differential diagnoses included in 1.4%?
Medullary carcinoma can have benign.
Excellent. Medullary carcinoma. Medullary carcinoma one. What else? Other participants.
Malignant phylloides.
Phylloides tumor. It's okay. Malignant and benign. Phylloides or malignant phylloides. Yes. Excellent. What else? It seemed to be, what about the density of these lesions?
Mucinous tumor.
Would you?
Mucinous tumor.
Mucinous, excellent. What else? Huh? What else? No more volunteer? Abir? Suhair? Hello? Hind? Medina?
Hello.
Yes, you are there?
Yeah.
Huh? Another differential diagnosis she described? Medullary? She described phylloides? What do you know about
Could
the
be
other
myth.
malignancies, breast malignancies?
Myth.
What are the other breast malignancies?
Myths.
Metastasis is excellent. Metastasis usually presented as a circumscribed masses. You see? What else? What other types of malignancy? Do you know, regardless of these the presentations of these circumscribed, what are the types of breast cancers or breast malignancies?
Ductal carcinoma in situ and invasive ductal carcinoma.
Lobular carcinoma.
Invasive ductal carcinoma, lobular carcinoma. Could it be invasive ductal carcinoma? Could it be lobular?
Yeah, it could be lobular.
But usually the lobular, okay, what else? Okay, I'll tell you the differential diagnosis. Pure mucinous carcinoma, medullary carcinoma, papillary carcinoma, phylloides tumor, intramammary metastasis, okay, and high-grade invasive ductal carcinoma. Why? What do you think? Why the high-grade type? So when it is high-grade, the growth, it will be rapid, concentric, no time, you see?
For
It is a mass
speculation.
oval or, yeah, no time for infiltrations. So it can present as a circumscribed mass, the high-grade invasive ductal carcinoma. Okay, so still we are talking about the margins. What is the difference between circumscribed and obscured?
Circumscribed, we can see the margins all around, but the obscured, we can see the margin from part, and from the other part, we cannot.
Okay.
And it's well defined from the part that we can see.
Yes.
Well circumscribed.
Yeah. And what about this part obscured? There is, if the obscurations is about 5–10%. Still, we describe it as obscured, or we describe it as something else. Other descriptors.
Maybe it will be
It will be partially obscured.
Is it necessarily to have certain percentage of the margins to be obscured by the adjacent parenchyma to use the descriptor obscured, or it is
I
open?
think, yes, I think if it is
Yeah.
more than 20 to 30% of the mass is obscured, I'm going to say it is obscured. If not, if less, I'm going to describe it as circumscribed.
Excellent, excellent, Medina. Excellent. So the margin is sharply demarcated with abrupt transitions between the lesions and the surrounding fatty tissue. It is circumscribed. Okay. If this circumscribed margins, you see, at least 75% of the margin to be well defined, sharply demarcated, to say this is circumscribed. At least 75 or more. If more than 25 of the lesion obscured by the adjacent parenchyma, then we will qualify it as obscured descriptors. You got it? When I'm talking about this part obscured by the parenchyma, it has to be more than 25% of the margin to describe it or to qualify it as obscured margins. You got? We'll have examples. And this obscured margin is a unique descriptor of mammography, unique mammographic descriptors. You cannot use it for ultrasound nor for MRI. It's only for mammography, 2D mammography. Okay, what about this lesion? Is it a circumscribed or it is obscured? The lesion projecting into from the anterior contour of fat glandular interface. What about the shape and what about the margins? Where are you?
Oval shape.
Excellent, well done. Who is talking?
And part of the mass is obscured by parenchymal tissue.
Excellent. Who is talking?
I'm Hana Ajuri. How are you, Dr. Raham?
Dr. Hana, welcome. How are you?
I'm fine.
You are welcome. I'm so happy to hear. I'm so happy to hear your voice.
I follow you from the first lecture.
Oh, you are welcome. Okay. Okay. So this is obscured. Why you said yes, it is oval? Excellent. It is oval and it is obscured. Why it is oval? Why it is obscured?
So oval because there is some undulation. So
yes, the undulations are few. The undulations are few, are large and few. Okay, excellent. And obscured because
the inner part of the tumor of the mass is obscured by the breast tissue.
Yes, but we describe that it should be.
Yeah, that is more than 25% maybe.
Yes, this is more than 25% of the margin of this mass is obscured by the adjacent parenchyma. That is why we qualified or classified as an obscured margins. Okay, and I remember this. It was soft tissue on ultrasound, and it's presumed diagnosis fibroadenoma. Okay, look at it and agree with you. This obscured, and the anterior portion is circumscribed, completely sharply demarcated from the adjacent fatty tissue, completely surrounded by fatty tissue, while this obscured by the adjacent parenchyma which represent more than 25. You got it. This part, if you look here, this is more than 25% of the mass obscured by the adjacent parenchyma. And what about this? Huh? What about this?
It's round,
Round.
Yeah,
round and obscured.
it is obscured. It's okay. It can be round or oval. It's regular shape, accept it. And it is indistinct. It is circumscribed. It is obscured. It's what?
Obscured.
Obscured. Why?
About 50% of it is obscured.
And this, when we talk about when we have a descriptions, we have to have a reasons. You see,
Yeah.
to mention, to describe, or to clarify, to characterize the lesions as obscured, we have to have two criteria. Part of the lesion circumscribed, part of the lesion obscured by the adjacent parenchyma, and the third is the obscure part is more than 25%. Not complete, but more than 25. Just you have to fulfill these criteria to say this obscured. When you describe it is obscured because the anterior half of the lesion is sharply demarcated, completely surrounded by the adjacent fat, with abrupt transition from the adjacent fat, as if I have a pencil and pass it through its edge, its margin, its outlines, while the inner half is not seen, obscured by the adjacent parenchyma. And I remember this case, also my case, and it was a simple cyst. You see, that is why is BI-RADS
After ultrasound, it's BI-RADS 2, but before
no,
it's 3.
it is that is why it is BI-RADS 3, because we can downgrade it or upgrade it by ultrasound. See, the circumscribed and obscured are probably benign, are BI-RADS 3, because we can downgrade it or upgrade it when we do ultrasound. Okay. Another participant. Where is Magdalene today?
I'm here, boss.
So here,
There is a posterior located oval-shaped obscure lesion, equal density.
okay,
Yeah.
welcome. Okay. There is,
Posterior located oval-shaped equal density obscure lesion.
obscured. You said obscured.
Partial, yeah, partial obscure.
Taib. What is next?
No,
What is next?
ultrasound.
What is next?
To do ultrasound.
Before ultrasound.
Before ultrasound, this lesion is not clear by this image, so I should do a magnification view.
Compression magnification.
Yeah, spot view.
Yes, spot. Also, she's my case.
Oh my God.
Now,
speculated lesion. Speculated lesion. Speculated lesion.
Yes, so this is speculated and indistinct. You see, now the
Yeah.
margins, not obscured margins. This is not an obscured.
Yes.
There is no circumscribed part. We said when we said this is just again and again and again. When you talk about obscured, you have to have part of the lesion circumscribed. Otherwise, don't say this obscure. Okay? You have to have part of the lesion circumscribed. And the other lesions, the other part, I mean, of the lesions is obscured by the adjacent parenchyma and should be more than 25% of the margins. So here I can say from the beginning, yeah, it seemed to be an oval. It seemed to be an oval opacity, but the margin, I'm not sure about it. I need to do compression spot view to see the margins. And we said before, you see, when you look for the margins, now it is obviously suspicious type of lesions. And it was invasive cancer. It was invasive ductal carcinoma. So indistinct and speculated. Some speculation is there, but the major is indistinct. You might find combinations of these type of infiltrations of the margins. And what about this?
Microlobulated.
Excellent, well done. This is a microlobulated, and this one?
Speculated margins.
Which one is speculated? This is more representative. This is more representative for the
Microlobulation.
So if you look, it is hollowly throughout, surrounded by fat, clear fat, but the margins are microlobulated. So when I have seen microlobulations, it means the margins are is it this lesion, how you code it? Birat, it will be Birat.
4.
4, excellent. Which 4?
4B.
4B, excellent. Why you said 4B? What is the positive predictive value of malignancy in this type of lesions of margins? Lobulated margins or microlobulated margins? Yes, you are right, 100%. It is B. Anyone knows?
I'm not understand your questions.
We said before, we said for the circumscribed, the positive predictive value of being benign, of benignity is 98 to 99. So
okay,
the chance of malignancy is only 1.4. For this, there is, it is suspicious. So this one?
Up to 50%, 35 to up to 50%.
No. So when we talk about suspicion, that means when we talk about suspicion, that means the probability of malignancy, it should be when we start talking about malignancy or suspicion for malignancy. So the probability
A up to 10%, B up to 35%.
From
two up to 10.
Yes. So 2 and more up to 10 is is
4A.
Yes, and
from 10 to 35, 4B.
35?
50, I'm not sure.
50, 50.
50.
From 10 to
50,
50 is B. And from 50,
to 95% is C.
C. Excellent. So this is B. Yes.
Yeah.
Microlobulations, margin characterized by short cycle undulations. For mammography, use of this descriptor implies suspicious findings. Positive predictive value is only 17%. So it is BI-RAD for B. Huh? This is a BI-RAD for B. Okay? Although completely surrounded by fat as we described, the microlobulations make it suspicious and biopsy revealed invasive ductal carcinoma for this one. So we have to be cautious not to report it as fibroadenoma. Someone might put these lesions look like very clearly demarcated to be reported as a fibroadenoma. And there are fibroadenoma can be presented like this. But since we have single suspicious descriptors, we have to take the suspicious features. We have to consider the suspicious features. See? And what about these? Huh? What is the margins here in these examples?
I think indistinct.
Which
Yes.
one, Dr. Rabab?
Yes. This on the left. Here is the lesion.
On the left is indistinct.
Indistinct.
Yeah.
On the right.
On the right is obscured.
Obscured. Why you said obscured? Who's talking?
Circumscribed.
No, there is someone, Khadija, or was talking. Her name is Khadija.
Yes, Dr. Rabab, it's me. Part of the lesion seems to be circumscribed, but there's a part of it that seems to be obscured. That's why I thought it was obscured.
You are welcome. You are welcome, Khadija.
Thank you, Dr. Rabab. Thank you.
Yes. You are part of our program, yes, in Sudan, graduated recently.
Yes, recently.
Oh, you are welcome. Congratulations.
Thank you so much.
This lesion, okay, these lesions, if you look, there is, I couldn't see abrupt transition between the mass and the adjacent fat. See? Throughout,
yes.
this is also indistinct.
Indistinct,
and
okay.
What is supporting you? Look for the whole breast. Is edematous.
Okay.
Is edematous. You see?
Yes.
The whole breast is edematous. This is a malignant
Yeah.
mass with indistinct margins.
Okay.
Here more clear, indistinct, but here a little bit subtle, but this is an indistinct. And both are my cases, both are malignant malignant cases. You see, this is an indistinct. And what do you think regarding the indistinct? The BI-RADS, it will be the positive predictive value. What do you think? It will be in the range of
C.
Why you said C, Maizulin?
Because by ultrasound we can reduce we can upgrade or downgrade the
You could not defend yourself now. Always you are defending yourself, but not at this time. If you can upgrade or downgrade, So we said that 3. And here you said 3 or you said C or C?
C, 4C.
Yes. طيب, if you can upgrade all of the lesions, you can upgrade or downgrade.
Yeah.
Yeah. But why the C? What is the positive predictive value? Do you know it? For the indistinct. Okay. Khadija, do you know the positive predictive value for the indistinct margin?
I'm not really sure, Dr. Bob. This is the first time I'm joining your course. Like, this is the first time.
You are welcome. You are welcome.
I haven't really been following. I just started today, so I'm just getting to like adjust to everything.
Okay, I
Yeah.
hope you will enjoy.
I will, inshallah. Thank you.
Okay, well. Okay, so any volunteer? Hint. What is the positive predictive value for the indistinct margin? Do you know?
70 or 73?
Oh, too much. You see, your inflammatory cyst can give you indistinct margins. Inflammation surrounding a cyst or abscess can give you indistinct margins.
So it will be A.
But still, the probability or positive predictive value is more than the microlobulated. Because microlobulated, we have stromal I forget the name, the hyperplasia and fibroadenomas, and these types of lesions can be presented like that. See, not all are malignancy, but still we have about 17% chance to be malignant. But what are the chance of indistinct margin to be malignant is more than the microlobulated, but still within the range of BI-RADS 4B.
I think 19.5.
What?
19.5.
No. You see, indistinct is positive predictive value is 44%. So still it is BI-RADS 4B. Okay? Still it is a BI-RADS 4B. Historically, they call it ill-defined, like circumscribed before it was well-defined lesions, and indistinct is ill-defined. But now no more ill-defined, we just say indistinct lesions. And it usually implies suspicious findings. It means no clear demarcations of the entire or part of the margins. See, sometimes you might see only part of which is indistinct, and you have to label it as indistinct. Since tumors might start to infiltrate from one part while the rest is still entirely intact, the lesions. You know that. So any part of the lesions is microlobulated or indistinct, it will be suspicious for malignancy, not necessarily to have the whole margins indistinct or the whole margins microlobulated or speculated to say this is the suspicious lesions. What about these lesions? It's also my case. Huh? What about the margins of this mass?
I think indistinct also.
Indistinct. It's okay. Okay, what else?
Some speculation.
Microlobulation. Yeah, speculations. Yes, there are speculations. If you look here, these are thin lines. These are thin lines. These are speculations. These are speculations. So what is speculated margins, the margins characterized by thin lines radiating from the mass. And usually implies suspicious. But did you see the BIRATs for the speculated?
Yes.
You have
Wow.
seen it.
Yes.
Anyone who did not see it? Who did not see what is the BIRAT here, and he can give us suggestion? What do you expect to be?
I think 5 BIRAT 5.
BIRAT 5. It is a BIRAT 5. Why it is BIRAT 5? Why?
Because if it is rated is highly suspicious and it need a biopsy.
Yeah, but this is the definition of BIRAT 5. But why?
Yeah.
Why do you expect? Why the others suspicious are BIRAT 4 and the speculated is BIRAT 5?
High positive predictive value.
Yes, high predictive value. Why? How much? How much is the predictive value?
Probability of malignancy more than 95%.
Yeah, definitely will tell. It is more than 95. It is 96. But why? Why it is 96? Because we have minimal, we have few lesions, few benign lesions presented as speculated margins. Very few. The majority of lesions presented as speculated mass are malignant. Only few presented with speculations representing a benign process like what? Examples? Can you give us examples of speculated lesions? And usually, when you see it as speculated, it will not be an speculated mass. Even the small percentage, mostly it presented speculation as distortion rather than a mass.
Scar tissue.
And the light. Yes, scar, post-surgical scar, post-trauma scar, and what else? Radial complex sclerosing lesions, stromal fibrosis. Few lesions, you see, some few mastopathies, hepatic mastopathies or so, very few lesions can give us this type of speculations. And if you look for the center of the lesion, you will not find the criteria of the mass. You will not see the center is dense. It will be relatively lucent and there is a speculation representing distortions. Okay, what about the margins of this? Shall I go more quickly or this is okay with you?
Ill-defined.
Huh?
Ill-defined.
Who is talking?
I am Heidi. Dr. Heidi.
How are you? You're welcome.
Thank you so much, Dr. Rabah.
Welcome.
We are too late, Yani.
No problem. You are welcome. You will catch. You will catch. Still, we are in the beginning of the course.
Inshallah, inshallah.
You can revise. You see,
Inshallah.
it will be. You will find it. Inshallah. Huh? What about this? Which type? Is it circumscribed? Is it obscured? Is it indistinct? Is it microlobulated? Is it speculated? Which one?
I think it is indistinct.
Indistinct.
Obscured.
Obscured.
Defend yourself. Defend yourself. Who is saying obscure? Describe why it is obscure. Who said indistinct? Describe why it is indistinct.
Obscured because part of the lesion is circumscribed, and more than 25% of the lesion is obscured by the underlying breast parenchyma.
Excellent, well done. And furthermore, can help you if she's telling you this area might be indistinct margins rather than just obscured. How you can defend yourself? How you can telling her, no, it is obscure rather than indistinct. Why?
I'm going to do a compression view.
No, without compression in this image, you can tell, I agree with you, it is obscured, but how
there
you
is
can...
architectural distortion?
No, you are telling part of the lesions is obscured and the rest, the area which is not obscured is circumscribed, and the obscured area is more than 25%. Is it the obscured area continuous?
No, it's not continuous.
Okay,
It's
where?
obscured in
What part?
2 parts.
Where?
The most anterior part of the lesion is obscured, and the most anterior and the most posterior part of the lesion is also obscured.
Posterolateral, anteromedial. Anteromedial, posterolateral.
Yeah.
And at this area, you can see what? There is adjacent parenchyma. There is adjacent parenchyma is present at these locations. While the anterior, it is being projected, the lesion is projected from the contour of fat glandular interface. And where there is complete fat, it is sharply demarcated. And even here, adjacent to the fat, it is demarcated. While where there is parenchyma, the lesion is obscured. This is how you can defend yourself. Okay? So this lesion, that was ultrasound, and how you can, here on mammography, it will be BI-RAD. Abir Medina, you have taken this, on based on
BI-RAD 3.
mammography,
BI-RAD 3.
BI-RAD 3. Okay,
Yes.
on the ultrasound downgrade or upgrade or what, or the same? It will be
Upgrade.
3. Abir, excellent, well done. Why you upgrade it?
Because it is a complex cystic mass.
Excellent, congratulations, well done. Because ultrasound demonstrates complex cystic solid component of a lesions. So it will be BI-RAD for biopsy. And biopsy revealed intracystic papilloma. Also my case, long time before. We reported as BI-RAD 4 for biopsy, and it was intracystic papilloma. Fortunately for the patient, was benign. Okay. So what about the margins, examples of this? I'm asking you, shall we proceed like this or just to inherit?
Like
Make
this.
it a little bit quickly.
I think it's a good method of education.
It is good to continue like this. Okay.
Yeah.
طيب, what
Yes,
about
doctor, it's okay.
what about this? What about these lesions? The margins of these lesions.
Circumscribed.
Excellent. Well done. Both or one?
Sorry,
Both lesions are circumscribed or one is circumscribed?
I cannot hear you well.
I'm asking, both lesions are circumscribed or only one of which?
Both lesions.
Excellent. Well done. Why?
I can see a clear abrupt between the lesion and the surrounding fatty breast, clear outline, abrupt outline, all over.
All over? And what about this? What
Um,
about this?
Yeah, but it is less than, sorry, it is less than 25%.
Excellent. Well done. Excellent. Well done. Yes. You cannot say, yes, you cannot say completely. Even here, you might see few areas obscure, but it doesn't represent 25%. So both are, I don't know, I stuck. Both are circumscribed. And what about this? What about this?
Yes, this marginal calcification, is it rim? But it's not all around.
Or it can be rim of, if I'll tell you this is a cyst.
This.
Milk of calcium.
It's milk of calcium.
Excellent, excellent. Milk of calcium. This is a milk. This is a fibroadenoma. The one here, small one, is a fibroadenoma, while this is ACR cases. You see, it is not my cases. This, they said this is a fibroadenoma, and this milk of calcium in a cyst confirmed on ultrasound. Okay, let us see these cases. Two from ACR and two from my experience. So tell me the borders. I'm going slow, so I would like by the end of the lecture, all of us to understand what are the descriptors of a mass. But still we have a lot of examples. So try to be a little bit quickly. Anybody knows? Just open his, unmute his mic and tell me what is going on. I put number for the cases, 1, 2, 3, not necessarily to start by 1. You can start by 3 or by 4. Otherwise, I might, you see, open the participant and say, select one of you.
I think one is circumscribed, 2 is indistinct. Yeah. 3 is
one minute, Medina.
One is circumscribed.
Are you sure? Okay, two.
Indistinct margin.
Excellent. 2 is indistinct. Excellent.
Yeah.
I agree with you. 2 indistinct. 3.
3 is circumscribed.
Excellent. 3 is circumscribed. Okay.
4 is obscured.
Do you think 1 and 3 is the same? Do you think that? 3 like 1?
No, not totally equally.
So?
Still no. 3 will be fine, but 1 not related.
Huh? Yeah. And what about 4?
4 obscured.
or obscured, or obscured. And when it looks a little bit,
Microlobulated.
no, it is not a microlobulated. If you look here, this part, circumscribed, while this part,
indistinct.
look here, this is fat, while here this is opaque. Where there is opaque, there is parenchyma, the lesion is not clear. Where there is fat, the lesion is clear. This is the definition of
Obscured.
yes. This is definition of obscured, partially circumscribed, mostly obscured by fibroglandular tissue. For biopsy, it was invasive ductal carcinoma. See? Because most of the lesion is obscured, is masked. Before we said the mask lesions, you see, is a little bit suspicious. It is a suspicious lesion. It's not a micro. It is not a microlobulated. Here, this is area not clear, and the margin, according to the description of the ACR, they describe it as obscured, partially circumscribed, but mostly obscured, and the result, it was ductal carcinoma high grade. And this is my patients. You have seen it. It was invasive ductal carcinoma, you see. And this is the ACR case, obscured, half is circumscribed. See, this is the anterior half here, while the rest of the lesions is obscured by the adjacent parenchyma, covered by fibroglandular, and for biopsy it was fibroadenoma. While this is my case, it is a circumscribed because the area obscured is less than 25%, and it was stable for 3 years. The presumptive diagnosis, fibroadenoma. What about this 1 and 2? Quickly.
One is indistinct.
One is indistinct, excellent. And I remember this case, it was an inflammatory cyst. This is the inflammatory cyst, not the cancer. Look how the inflammation surrounding the cyst and make it completely indistinct. Okay. And what about the 2?
Obscured.
Obscured. Excellent. Because part is circumscribed and part is. So, in conclusion, regarding morphology, we have 3 shapes, either regular, including round, oval, or irregular. No more lobulated. No more lobulated descriptor regarding the shape. Regarding the margins, circumscribed or partially circumscribed, obscured. Probably benign. Then microlobulated, ill-defined or speculated. And a mass for which any portion of the margin is indistinct or microlobulated or speculated should be classified on the basis of the latter, the most suspicious component. Even part of the margin, not necessarily to see the whole margin indistinct or speculated or microlobulated. If there are part of which with these suspicious margins, we have to label it as suspicious mass. Okay? So we finish the morphology now, and I hope all it is clear for all of you. Okay, let us go for the density. What is the density? What is the mass density? Any volunteer unmute himself and just tell us what is density?
the density in relation to the breast tissue, either equal density or low density or high density?
The whole breast?
No, mainly the fibroglandular.
Okay, the whole breast, if the whole breast is occupying by, if fibroglandular breast tissue occupying the whole breast. So you will relate it to the whole breast, or you will relate it to
an equal volume of the mass.
Excellent, well done. That you are going to relate the X-ray attenuation of the mass to an equal volume, to attenuations, expected attenuation of an equal volume of fibroglandular tissue. See? And the mass density is really significant predictor of malignancy. Okay? Most breast cancer will be equal or higher density of normal fibroglandular. So, regarding the density, we have high, equal, or low. High, the mass X-ray attenuation is greater than the expected attenuation of equal volume of fibroglandular tissue. We'll see example for that, don't worry. It is suspicious, is significantly associated with malignancy with predictive value of 70%. The likelihood of cancer is 70% with high density. While equal density before historically described as isodense mass, isodensity. Now, no more isodense, we are saying equal density, and here the mass density is the same as expected attenuation of an equal volume of fibroglandular tissue. And the likelihood of breast cancer in this type of mass density is 22%. While the low density, the mass X-ray attenuation is lower than the X-ray attenuation of equal volume of fibroglandular tissue, however, not fat. We are not talking about lucent. We are talking about radio-opaque mass. Here we are talking about a radio-opaque mass. Radio-opaque with low density and radio-opaque with high density, and in between is equal density. And the low density, the risk of cancer is very, very low, okay? But not completely eliminated. It is there, but it is low, extremely low. Okay, these are examples here. This is a high density. This is a high density lesions. And this is equal density mass. And this is a low density mass. You got it? Okay. I have 3 examples of invasive ductal carcinoma. When high density, equal density, and low density. If you compare these lesions with the adjacent, okay, fibroglandular tissue, you will see it even lower than it, but it was invasive ductal carcinoma, and this is rare. So, again, to remind ourselves, the density of a mass is an X-ray attenuation of the mass related to the expected attenuation of an equal volume of fibroglandular tissue. Okay. What about the density here?
The first one is equal.
Which one? This one?
No, I'm talking about the other side.
This one?
Yeah.
Equal to this?
I compare it just with the tissue near. If we compare it.
Near is fat. Near is fat. You have to compare. You have to compare with fibroglandular. And this
So
compare with fibroglandular. So
the first one is low density.
And the second
is equal density.
Equal to this?
Lower.
Lower. And this one? Look how it is large, but still
low density.
So these are low density. This example is a single dilated duct or a single ductasia. And this case, it was a DCIS, and that one is a simple cyst. So the three examples are low density. It means that X-ray attenuation of the mass is less than the expected attenuation of an equal volume of fibroglandular tissue. But low density mass though it might represent a microcyst, and in this case, or most of the time, is very well not being a malignant, but we have to be cautious. We have to work on it. See, this is clearly circumscribed. There is halo, and obviously, and I can see it even by ultrasound. And this is circumscribed low density, but this is indistinct. So I suppose not to say this is low density and ignore it. You see, still there is a probability of being malignant, including in a low density mass. What about this? Invasive ductal fibroadenoma, simple cyst. The examples is
I think isodense.
Who said ISO?
Me, Heidi.
Huh?
Heidi.
Who?
I am Heidi.
You are welcome. Your name is Heidi or Heidi?
كله مع شيرك.
Before I was calling you as Heidi.
Okay, welcome. Welcome.
Okay, so you are right. It is an ISO, but we said the ISO is a historical descriptor. The current descriptors is, or the updated one is
equal density.
Is equal density. So and what is the equal density? What does it mean, equal density?
Ecogenicity of the lesion equal to the fibroglandular tissue of the breast.
Equal to the fibroglandular generally, or equal to density of the same volume. Historically, as we mentioned, equal density, historically isodense. X-ray attenuation of a mass is the same as or equal to the expected attenuation of an equal volume of fibroglandular tissue. Okay. What about the density here? Where are the lesions? Is it one or multiple or two or unilateral or bilateral? This 24-year-old lady presented 8 months after delivery with bilateral breast lumps. So you have a hint. Sarah Almak,
Multiple lesions, lower density than the breast parenchyma.
excellent, excellent. Abir or Heidi or whom? Your voice similar.
Yeah, I'm Abir.
Abir. Yes, bilateral. Where in the where are the locations? Huh?
They are within the greatest part of the fibroglandular tissue.
Where are the locations of the masses? Agree, are low density, excellent, well done. But where are the masses?
They are distributed within the fibroglandular tissue.
You mean these areas? These are the fat lobules. This is the normal fat lobules of the breast. No. I thought you got it.
Sorry. There is.
I think one is in the retromammary area.
Who's talking, Suhair?
No, I am hiding.
Heidi, huh? Where?
Retromammary area.
What do you mean by retromammary? You see at the back of the breast?
Yes. And when retro.
Which side? Which side?
I see, I'm Suhair. I see it is the upper
Where
part.
are you, Suhair? I was looking for you.
It is the upper part of the breast bilaterally compressing the parenchyma, the breast parenchyma bilateral at the upper part of the breast.
You mean this area?
This large area, yes, this large area, yes.
No, this is part of the normal breast. This is normal breast. This is not the one. You mean here? No, this is not the one.
Yes.
Do you think this is normal?
No,
this is not
This
No,
is the
this-
area that I talk about, Dr. Rabab.
Heidi.
Yes.
That is why I asked. That is why I asked you at which side. I got it. I thought you are talking about it. I asked you
confused
which
about the
side. You
area.
didn't tell the right side.
Yes, right side.
Yes. This one lesion.
Yes,
This is
one,
one lesion, and the other lesions are
retroareolar.
retroareolar. This, you see this one, and that is the other. So what do you expect? We said yes, you are correct, Heidi. You said it is low density, excellent. This is a low density, and what do you expect to be? These are
Fibroadenomas.
Post delivery maybe galactosome.
excellent. Who's talking?
I am Heidi.
Heidi, yes, you are right, 100%. Yes, this is a galactoseals. And why are low density? You will find the answer here on ultrasound. What you have seen here on ultrasound? You have fat fluid. Galactoseel contain lipoproteins. That is why, and according to its component, it might be a low or equal density. Very rarely to be a high density unless it is pure cyst. See? This is a galactoseals. Follow up for the same thing. Look for this. Now are clear?
It is the same patient.
Yes.
What do you think?
After follow up, still the lesion.
Now are clear. Now becoming
Hyperdense.
not hyper, now are equal. Now are equal density, but it depends on the component. It is equal density, bilateral, multiple galactoseals. How you know this is the same patients? Look, the lesions, for that lesions, bilateral retroareolar and the one in the right axillary tail. This is the one in the axillary tail, almost same size and shape, and those are the retroareolar. You see? So the component of galactoseals from time to time can be changed. Okay, these bilateral multiple galactoseals equal density, and there it was low density. What about this mammogram regarding the density? We're talking about densities.
High density.
All or one lesions, or how many lesions do you have?
I'm talking about the left one.
Excellent. The left one is high density. Even the left, you have more than one masses.
Yes, there is one just very small above it.
Multiple equal densities.
Yes. And can you see it here?
On the right are multiple bilateral high density masses.
Equal density lesions.
High density masses.
All right. These are high density. As these are high density.
No, this is equal density.
Low.
And at the left, high density.
This is a high. This is high, while the other, if you compare with the equal,
on the right.
Yani, if this one you compare to the equal volume, you will find it as
low. High density. No, high density.
How come? This one is high. The largest one is high.
It's high density, yes.
And this one is relatively high. By the others
are equal density.
Are equal density, which represent multiple cysts. When you have seen like that, different densities, multiple lesion, you expect to find cysts which were shown on ultrasound. What about this regarding density?
High density.
High density. Okay, other descriptors.
High density mass, speculated mass.
So now we are talking about morphology, shape, margins, and density. So,
high density.
High density.
Speculated.
So if you are going to start with, you will start by what?
Shape.
With the priority of descriptors. We will start by which is the most important.
Shape. The shape, it is the micro-lobulated.
You start with us from the beginning, so here?
No.
That is why. I missed you in the beginning. I was looking for your voice. That is why. And I was going slowly, very slowly. So as everybody could concentrate and understand all of these descriptors. So when we go through the examples, it will be easy for us to describe the masses. And since you were not there, you cannot describe it well. But try, no problem to try.
I think it is obscure hyperdense.
Who is talking?
Heidi.
Why you said obscured? Okay, I accept obscured, no problem. you think it's obscured. So how you are going to manage this patient? The mass is high density and obscured. So what is next? Your approach. What is next?
Ultrasound.
Ultrasound.
Magnification, compression view.
Compression magnification view or spot compression to see the margins and to see the shape and morphology. What is your impression now?
Indistinct.
Yes. Irregular. Shape. Indistinct. Speculated margins. So it is, and I suspect as if there is some calcification, but not clear. So now it is highly suggestive of malignancy.
IRAD 5.
Next it will be, yes, it is BIRAD 5. Next it will be
Biopsy.
Biopsy.
yes. Look for that.
Or biopsy.
Yes, it was a BIRAD 5. This categorized as BIRAD 5 or coded as BIRAD 5. We said even only the density is BIRAD 4. The margin, the shape is BIRAD 4. But if the shape only irregular, BIRAD 4. But shape is BIRAD 4, density is BIRAD 4, speculated is BIRAD 5. So it is BIRAD 5. Okay. So researches has indicated that high mass density may indeed improve the prediction of malignancy. The predictive usefulness of mammographic attenuation or the mass density remain controversial for long times, but the latest editions by RATS conclude that radiologists should consider mass density as valuable descriptor that can stratify risk. You have to consider it. And despite of these important clinical implications, breast density is at least reliable among mammographic features of masses, especially the morphology. Among morphology and density, it is the least. The margins, shape, then density. So why? Why? Because density is subjective. Evaluation that subjective evaluation that the optical density cannot be directly measured on the 2D conventional mammography due to superimposition of the structures. However, the digital tomosynthesis and the computed tomography would allow direct measurement of attenuation, but these are not in routine clinical practice. And the mass density evaluation can be difficult when the breast is predominantly fatty. How you can relate it? Which part? And if there is little fibroglandular tissue to compare with, or if the only available surrounding fibroglandular can be seen through the mass. So how you can compare it? It will be difficult to compare the density. So this is one of the limitations. Also, large mass force the radiologist to make a comparison on the basis of unequal volume of fibroglandular tissue and the mass. And the majority of masses are isodense. Most of the masses are isodense. Little or few are high density and few are low density. These are relatively infrequent. Also, this is one of the limitations. However, these changes in evaluating mass density do not eliminate the value of mass density as an indicator of malignancy. You see? Okay, we finished radio dense or radio-opaque mass density related to the radio-opaque. What about the fat-containing density? What do you know about fat-containing density?
They are regarded as benign lesions, para-2.
Excellent, well done. Regarded as para-2 benign lesions. What does it mean? يعني the descriptions, it means what?
These lesions,
low density lesion.
Low density?
no, it's the same density of the fatty tissue.
Yes, it is lucent. Are containing lucency, that means density of a fat. Okay, fat containing. Why we say it can be purely fat contain mass, or it can be
partial.
Okay, we call it the partial. We call it
fat-containing lesion.
The name of the region.
Mixed density. Okay, give me examples. Give me examples.
Mixed density hamartoma.
Hamartoma, excellent.
Pure density, like an oil cyst.
Excellent. Excellent. Someone say lipoma, also excellent.
Yes.
So where?
Yes.
Hello.
Yes. Yes. Lipoma is
Lipoma, oil cyst. These are pure fat.
Pure fat density.
And mixed density hamartoma. What else? What else? What are other examples?
Fat necrosis.
Fat necrosis, excellent. Yes.
Galactosile.
Galactosile, excellent. Well done. What else? What else?
Saline implants.
Saline implant.
Intramammary lymph node.
But it's not fat. Intramammary, excellent. Intramammary, yes, you are right. Okay. And hematoma. So the density fat, before we are saying radiolucent, radio-opaque masses, density of radio-opaque and radiolucent. Now the descriptions is fat containing masses. That is it. Fat containing masses instead of radiolucent. The fat containing masses, the descriptions include all masses contain fat. Either the whole lesion is of fat density, as in lipoma, oil cyst, and sometimes galactosiles, while galactosiles can be also included in the mixed density. You see? And the mixed density is hematoma, hamartoma, intramammary lymph node. These are the common examples. A fat containing mass will almost always represent benign mass, para-2. See, with positive predictive value 0 for malignancy. Almost always. You see, is a benign mass. Why you are saying like that? So there is chance, extreme rare. Can you tell me, what do you expect? Any chance for breast cancer to include fat?
Yes, when the mass is so big to engulf the fat, adjacent fat.
Yes, engulfing the adjacent fat, but this is not a mass in this case. Usually not in a mass, usually in lobular carcinoma or infiltrative type of cancer, infiltrative, presenting like asymmetry, you see, within which you might find fat lucencies or fat densities. But as a mass, discrete mass, discernible,
Liposarcoma.
are benign, all are circumscribed. All are circumscribed. You don't expect to find for a circumscribed fat, pure fat or mixed density lesions to be malignant, but there is chance, but very minimal chance. I have experience of 2.
Liposarcoma.
For me, I have 2 cases, and at that time, when I did search in the literature, I found 14 cases only worldwide. ها
I'm not sure, Dr. Rabab. Assalamu alaikum, أنا دكتورة سارة. But I think the glandular tissue within the hamartoma can
Excellent, Sarah Almat.
أيوة.
You are welcome. You are welcome. You are right, 100%. Yes, continue.
Okay. The glandular part within the hamartoma,
Yes.
يعني any malignancy can occur in this glandular part.
Yes, you are right. Excellent, well done. Congratulations. Congratulations. Yes, hamartoma is breast within breast. It is a small breast, encapsulated part of the breast. You see, containing all elements of the breast itself. Containing fat, containing stroma, containing glands. See, but it is a small breast. So there is chance of breast cancer to arise within a hamartoma, though it's extremely rare. But I had 2 cases in my experience of malignancy arising in a hamartoma. And it was when I did search, as I told you, it was at that time, it was only many years back, it was only 14 cases worldwide. Thank you, Dr. Sarah.
شكرا لك أنت يا دكتورة رباب. يديك العافية.
الله يعافيك. ها؟ What is this? So we are talking now, we are talking about fat containing masses, not a radiolucent mass, fat containing mass. So just I need someone to tell me, to describe what you have seen and to give a suggestion. You have a clue in the image.
Circumscribed lucent lesion with
We said fat
with
containing. We said the description is fat containing lesions. Okay. Excellent. You are doing well. Continue. Just I'm trying to correct you or to remind you by the, instead of saying lucent, to say fat containing. Huh?
Okay. With margin.
Okay.
This is representing a capsule. This is a lipoma, breast lipoma.
Okay, suggestion. Huh? Can you
Yeah.
change your mind? Can you change your mind?
Yes, I can.
Ah.
Because the breast is fatty, this could be a hamartoma. Because all breast is fatty, but I put a benign lesion, BIRAT2, could be lipoma or hamartoma.
It is BIRAT2. But how come a hamartoma without any opaque? It is not a mixed density. It is pure
but the background of the breast also almost fatty breast. So it could be involuted.
You have a small, very minimal. Even this, you did not see it within. And is it a single lesion? Is it a single one?
No, it is either overlap 2 lesions.
Yes, there are 2 overlapping lesions, yes. And What about this, more or less? So
let me see. This oil cyst looks like
yes,
oil cyst.
when you have seen multiple fat containing masses, think about oil cyst or fat necrosis.
Looks
Okay.
like lipoma. Yeah.
Yeah, because it is large. Unusual for
Okay.
fat, unusual to see oil cyst as a large. But
Yeah.
usually lipoma are not presenting like this overlapping. And you can see here some dystrophic, evolving dystrophic calcifications here and this there. Okay. And it is complete fats, yes. There is no difference regarding the complete or the whole fat containing mass with surrounding, because the surrounding is a fat. That is why you have seen this as pseudocapsule, thin, opaque, okay, rim surrounding the mass. Even here, this is the thin, opaque surrounding the mass. This is an oil cyst, Barat 2. Fat containing mass, circumscribed fat density mass with a thin pseudocapsule, not capsule. Okay, the mass is fat density and therefore it is benign. And here, what about this? Quickly, now you should be like this, very quick.
There is a fat containing mass mixed density. Fat
Excellent,
and
mixed density.
density.
You are talking about what? About what? Which one?
At the left side, the left one. Circumscribed fat mixed density. At the upper
Excellent.
part of the breast.
Excellent.
This is most likely representing hamartoma. The right one, yes, the right one is of partially obscured margin and containing mixed density and fat density, with a fat density at the lower part of the breast. This obscuration of the margin due to overlapping of the glandular tissue.
Excellent.
Almost representing hamartoma.
Yes, these are two examples of hamartoma, and when you have seen the fat, adjacent to the fat, you will see the pseudocapsule, but adjacent to the glandular, you might not see the pseudocapsule, and these are examples of hamartoma, a radiolucent or fat containing lesions, mixed density. Okay, and what about this?
Rounded mixed density. Rounded, circumscribed, mixed
Which one?
density.
Both or one?
On the left side of the screen.
Yeah, so when you talk, tell me you are talking about the two, about one, you are right. Huh? Left one is a circumscribed, mixed density, fat containing.
Hamartoma.
And what about this? This is what?
This could be the nipple.
The nipple here?
So calcification.
Is it calcifications? Why you said the nipple hint? Why?
Because they usually put a marker.
Yes, it is a marker. It is a baby markers. So
it's a marker.
It is a marker. It is obviously it is a marker, but is it necessarily the marker to be at the nipple only? We describe it before. We said it can be at the side of one abnormality. This is a large mass.
This is a mole. Skin mole.
This is a large
Skin
mass.
mole.
Why skin mole? Why? This is a hamartoma. She's right. But it is a palpable abnormality. At the site of palpable abnormality, sometimes the radiographer might put for you a BB marker.
Okay.
Okay?
I said mole because يعني almost surrounded by lucency all over. So that make me confused.
No, this is a hamartoma. It is a large, it is a hamartoma. It is mixed density. Okay, what about the lesion on the right? The mass on the right. Khadija, are you following us? Or you left? Huh? What about the right? The lesion on the right?
I'm Suhair. On the right side, there is a circumscribed, large, retroareolar mass of mixed density and interposed with multiple fat lobules, representing large hamartoma with pseudocapsule, thin pseudocapsule.
You are right, but again, your description again.
There is a large retroareolar mass of mixed density.
Excellent. Why you said of mixed density?
Because multiple small fat containing lesions interposed between these high density, representing fat density and a thin pseudocapsule.
Yeah, and the thin capsule, we have seen it because at the periphery, there is fat density also, thin or fat density at the periphery. So what does it reflect? Why I brought these different type of hamartomas? What does it mean?
It means
What is the
contain large
message
amount of glandular tissue and a small amount of fat.
So
large amount of glandular tissue on the right one, representing hamartoma.
It
Yeah,
depends
what
on
about
the
that?
composition of the breast.
Why hamartoma? Why?
Because it contains fat
Why?
lobules.
No, I'm asking why these are hamartomas. What is the difference between these and these? These are all hamartomas.
Depending on the composition of the breast itself.
Excellent. Composition of the breast or the hamartoma?
The hamartoma contain on the right containing a large amount of glandular tissue.
Excellent, well done. You see that we said hamartoma is small breast within breast. It is a breast within breast. So it contains all of the components of the composition of the breast tissue are within. What is that? What is the other name of hamartoma? What is the other name?
Fibrolipoadenoma.
Fibrolipoadenoma or adenofibrolipoma or whatever. So these are the components: stroma, fat, and gland. What are the main components of the breast? Same component of the breast. So sometimes the hamartoma-like breast, it might be contain almost the whole. It represents fibroglandular with paucity of the fat. Sometimes fat might be microscopic. You might need to do MRI to see, because MRI it has high tissue contrast to see the microscopic fat. And even sometimes even by MRI difficult to find or to see this microscopic fat. Sometimes it can be purely or mostly fat, as in this case. You see here the gland is very small. Fibroglandular are a small area, while the most of the region is fat. here almost half, see? And so the component between different type is of hamartoma, it differs, you see? So it is a lipofibroadenoma or fibroadenolipoma, or it depends. Okay, huh? What about this? Aywa?
There are multiple. I'm talking about the left, the image on the left side of the screen. There are multiple oval, well-defined fatty lesions in the lower part of the breast, in the anterior and middle thirds.
Again, Hind.
I can see that there are multiple oval, low fat density masses in the lower aspect of the breast, in the anterior and middle thirds.
Which one? Which view?
In the MLO view.
In the MLO. What does it represent?
Liposurgery.
No. And this is the same patient here on the CC view.
So I want to ask, there is no, these lesions are not there, or the diagnosis is wrong?
It is there.
Okay. So, and there is some calcification.
Yes,
So,
okay.
Could it?
No, you are right. You are right. This is different patient. Excellent. Well done. This different patient, but same diagnosis. Sorry for that. For mixing. Or confusing. Same diagnosis, different patient.
Okay. Oil cyst.
Accept it. It can be. But if it is not an oil cyst, by location, what do you expect by these locations? If you look here, look for these, how it
Galactoseals,
how it goes.
Ductal
distribution, ductal arborizations, yeah. And there is low density and surrounding with thin halo. So these are dilated
ducts.
Yes, this is ductectasia containing
milk.
Or yes, it can be milk, it can be just a lipoproteinaceous material. Not necessarily to be a milk. Okay? Lipoproteinaceous, that is why you make it low density. And this also the same, giving
a level.
Fat fluid levels. So she is not a lactating woman. She's old lady, little bit above middle age, the two ladies. So what do you expect? Ductectasia with lipoprotein It can be
or galactosyle.
We said it is not a galactosyle. It can be accepted to be a galactosyle in the differential diagnosis. But what is the differential diagnosis for galactosyle? If not a galactosyle, what could it be? Not a galactosyle. And usually a galactosyle usually not seen as this is arbrized, you see, ducts, multiple mildly dilated ducts, see, containing this low density fluid. Is ductectasia containing lipoprotein? It can be isolated ductectasia or part of ductectasia seen with in which condition?
Hyperprolactinemias.
Okay, so these are the etiology for ductectasia. We said either isolated ductectasia or part of ductectasia can
Becky
be part
disease?
of
Becky disease?
fibrocystic. These are case of fibrocystic, you see. This is a fibrocystic patient. See fibrocystic changes. In fibrocystic changes, the ducts or the cyst even might contain a lipoproteins. That can be seen and can be presenting as fat containing mass. So breast cancer masses never contain fat. Masses put, you see, line under masses. Never contain. So if it is radiolucent or fat contain, mixed or completely fat contain mass, it will be Barrett 2. It will never be malignant unless, as we mentioned, the exception, extreme rare exceptions of hamartoma. Although may entrap fat as seen in case of asymmetry or infiltrative process. If the process is open infiltrative, extending, infiltrating a tissue, in between, you might find the fat. But as a discrete circumscribed mass, you will never see fat within a cancer. If you have seen in a discrete mass fat, it will be Barrett 2. That is it. Okay. So we complete the morphology and density. Let us see what are the associated features. And then go for the size and locations. What are the associated features? So it's not a descriptors limited to the mass. Associated features can be seen with other mammographic abnormality, with asymmetry, can be seen with calcification, can be seen with distortion and so on. Okay, these associated features. The main descriptors for the mass are morphology and density. Okay, and if we have a lesions, we have to know the size of that lesion and where is located. And regarding the associated features, is not unique to describing a mass or describing a mass. Okay, so what do you expect are the associated features? What are the associated features on mammography?
Skin thickening.
Skin thickening, excellent.
Nipple retraction.
Nipple retraction, excellent.
Distortion.
Distortion.
Lymph nodes.
Lymphadenopathy.
Lymphadenopathy.
Architectural distortion.
Generalized breast edema.
Edema, excellent. اللي هي representing as edema representing as mainly
Trabeculation.
trabecular thickening. Okay. Anything? The mass can be associated with also calcifications. Excellent. Okay. So what are the associated features here with this mass?
Skin thickening.
Only thickening?
Subtle nipple retraction.
Skin tethering.
Excellent. There is focal skin thickening and retraction or tethering signify adjacent skin invasions, locally advanced cancer. It's okay, on the left. But it is far away from the nipple, so might be related to the disease. Yani, this thickening, you see, might be related to the lymphatic blockage and with slight tethering or retraction, I mean, or it might be sequelae of previous bacteriaceae, and which is more common. And the other case?
Lymphadenopathy.
Associated lymphadenopathy, excellent. Okay. Medina.
Hi.
Associated findings are?
Breast edema.
Excellent. In terms of? Yeah, we described it before. You mentioned, and I asked you how it will present, and you were describing what it can be presented.
Trabecular thickening.
Trabecular thickening and skin thickening.
Yeah.
Okay, skin edema, trabecular. This is skin thickening and trabecular thickening. It's okay, associated with the mass. Okay, and here we have two cases, more or less the same.
Nipple retraction.
Nipple retraction. It's okay. This is a cancer. But if I told you, I told you this is not a cancer, surprising, yeah?
Yes.
This, how you can describe the lesions? Is dense and the adjacent areola is thickened and retracted, and there are multiple equal density masses. This is high density, but there are multiple equal density masses in segmental distribution in the upper breast or the outer breast if it is CC. It is a CC, it is outer breast. So this is 3 years earlier. The same patient 3 years earlier. Look for the nipple. So definitely nipple now is retracted. This is one of my very interested cases in which the cancer mimicker or the lesions, benign lesions simulating malignancy. What do you expect to be the pathology in this case?
Fat necrosis.
عبير؟
كيف دكتور رباب؟
Who is talking?
نهال.
أهلا نهال.
كيفك تمام؟
أي النهالات؟ هلا. نهال مكة ولا نهال قطر؟
نهال قطر.
أهلا نهال، ازيك؟
الحمد لله، الله يسلمك.
من زمان عنك.
أي والله.
أهلا
من
بك.
قبل معكم.
أهلا وسهلا، شرفتينا.
الله يسلمك.
طيب.
I think it's fat necrosis because it's mimicking. It's
Yes,
very
fat
mimicking.
necrosis is one of the mimickers. But do you expect 3 years it will be fat necrosis like this, high density? And usually fat necrosis is not presenting as a high density.
Yeah.
Inflammatory
and it was more circumscribed. Now it's getting changing shape a little bit, get lobulated and infiltrating into the areolar skin with nipple retraction.
Inflammatory
Scarring tissue.
Yes, this is it is associated with scarring. Yes, you are right. But what are the types of
Bagets disease.
what?
دي بوسيرجيكال لأنه هنا عندي في الصورة السيريس برير عندي equal density lesion or cyst.
It is high density in both. It is high density, but within 3 years, some involutions occur in her breast. You see, getting more involuted, less parenchyma. It might be even more than 3 years.
Bagets disease.
Sclerosing.
Sclerosing, yes, it is something, yeah, it can be some sclerosis, some fibrosis, some associated fibrosis occurs. I'll show to you later the full case, but it was a papilloma. And I had more than one papilloma presenting like cancer. You see? And even, you see, multiple papillomas. Look here, these are multiple papillomas, obscured here by the parenchyma, but here the breast involuting after many years and might be even growing. And these are multiple. And at that time, I was confidently reported this case as BI-RADS 5. But I don't know about the 3 years early follow-up. It was not presenting, it was not there. See, this image, it was not available. And even I had no idea about it. It was only report this case, you see, as BI-RADS 5. Multiple lesions and some sickening and retractions and so on. And I got surprised by the result when I came back from my exam FRCR. I went to the FRCR and I came back and I found the surgeon sent me the result was a papilloma. Was so surprised to me. Okay, and I suspect you also. Nobody comment. Or all of you kept silent. Okay. What about this one?
Microcalcification.
Yes, tell me the mass is associated with microcalcifications. Okay.
Yeah.
Benign or malignant? Just give a hint.
Okay, the mass itself, I thought that you are asking about the associated feature, that's why.
But sometimes the associated feature point you toward benign and sometimes associated feature guide you. Upgrading your lesions.
Okay, this is coarse heterogeneous microcalcification. The lesion itself, I will talk about the mass itself. It is irregular.
Yes.
Indistinct. It is high density.
Yes.
And it is associated with microcalcification.
Yeah.
And
the microcalcification, how you characterize the microcalcification?
It is of different shape and size.
Yeah, so it is
pleomorphic.
It is a pleomorphic. So it is BI-RADS
5.
So before the microcalcification, It can be inflammatory process, yeah? If there is
Yes.
no, I will put it 4.
Yes.
Without microcalcification, it can be 4. Can be 4C. But with microcalcifications, you see, the other papilloma I had reported before, and even after the biopsy, the result, the second case, they told me, the surgeon called me and telling that the biopsy turned out to be a papilloma. I told him, no, this is BI-RADS 5, go and remove the lesion. He went and removed the lesion, and it turned out also like this. It is not the same case, but in this case, it was irregular, associated with calcifications, and so ugly, and it was just a papilloma. You see, this case from the literature, it was BI-RADS 5 and proven to be invasive ductal carcinoma along with DCIS. You see? And what about this one? Quickly, finish the
An irregular high density mass. This is an irregular high density mass associated with branching microcalcification.
Excellent, well done. Describe more the microcalcification. Do you remember? Do you know?
This is a
yes, you are
branching.
right. Yeah,
Branching.
branching.
Yes, branching calcification.
Branching. Other name is fine linear calcification. When we said branching or fine linear calcification, we are describing which descriptor regarding the calcifications. The calcification described by two descriptors. You remember? Do you remember? Distribution, and when we said fine branching, we are talking about distribution.
No.
We're talking
Distribution, it's segmental.
Yeah, we are talking about morphology.
Morphology,
fine,
yes.
This is the morphology. The morphology, fine, linear, okay, or casting,
or linear branching.
Or
yes.
branching. This is a morphology, which is highly suspicious. Yeah, it is almost BI-RADS
4C.
4C, excellent. And the distribution is here.
This is linear.
Also linear. Also linear, and you can say segmental. You can say linear, accepted, or
segmental, yes.
is accepted. Both regarding the distribution are BI-RADS.
Also BI-RADS 4.
For what?
4C.
Also 4C. The linear is this is the distribution is 4C. So distribution is 4C, and the morphology is 4C, and the mass, high density, is 4C, and irregular is 4C. So it will be BI-RADS. Now
5.
It is BI-RADS 5, multiple descriptor. So most likely this is invasive cancer, and this calcification is DCIS. Okay, so dense irregular mass, as you describe, with indistinct borders or margins, and fine linear calcifications extending linearly from the posterior edge of the mass for 3 centimeters. Okay, the mass reflects invasive ductal carcinoma, and the calcification consistent with DCIS, with necrosis. So it's coded as BI-RADS 5, highly suggestive of malignancy and biopsy indicated. And that, what is the significance for that? The distribution is essential for surgical excisions. For the disease extent is really important. You see, because they have to remove it. And since it might not be palpable, it has to be bracketing with a wire. The whole extent being bracketed by a wire, guide wire, for the surgeon to remove it. This is very essential. Otherwise, the patient might come with recurrence. So, palpable or mammographically detected masses with linear type calcification most commonly reflect invasive ductal carcinoma with associated DCIS. Okay, and look here. If you look for the CC view, you will just describe an irregular mass. But when associated spot compression, you can confirm the speculated margin as well as pleomorphic calcification, make it birat. Instead of just irregular mass on the CC view, it will be birat 4C, but after compression, spot compression, it will be birat 5.
5.
Okay, so the associated features are skin retraction, nipple retraction, skin thickening, trabecular thickening, axillary adenopathy, and associated calcifications. You see? Okay. So we complete morphology density, associated feature. Let us see the size and location of the mass. So what is the difference between 1 and 2?
One lesion and two large size lesion.
Okay, huge or large size lesion on 2 and a small lesion in 1. I remember the case when this patient presented to us with subtle focal asymmetry with group of calcification, and we recommend for her biopsy, and the patient disappeared to appear after 3 years with this still small lesions. See this one. This is after 3 years from the first one, but I missed the earlier image. I could not find it. See, while the other one, I remember that it was. What do you expect the pathology in this type of cases?
Phylloides.
Phylloides. It was a phylloides tumor. See, so but I think it was a malignant phylloides. If you look here, this lesion, how it's high density one, and what about the margins?
The anterior margin is indistinct.
So if we have a small part indistinct, the lesion, it will be indistinct. It was malignant phylloides. See, here it is, these all indistinct, and this part is also indistinct. So since there is part indistinct, the lesion, it will be indistinct margin, even if it is focal area. And this lesion, it is relatively high density and is irregular and is speculated with
margin.
Yes, with fine linear calcifications. See, with malignant type of calcification. So regarding the size, malignancy can be small, can be large, but we have to describe, we have to label, we have to give in the report the size and important implications on tumor stage for selection of treatment. Okay, and it's also predictor for prognosis. So estimation of tumor size is basic in order to decide the type of treatment for breast cancer. And as we described earlier with Abir, they said to you, don't measure like that. Haphazardly. You have to look for the maximum dimensions of the lesions. If oriented in any directions, look for the maximum and take your measurement, and the other one, it has to be perpendicular to the first one. This is the correct way, the longest dimensions and perpendicular to it. This is the way how to measure the mass on mammography. Okay, and the lymph node will take from the end to end. We have no here, mostly we have no cortex like on ultrasound. On mammography, just take the short axis. Okay. So remain is locations to describe lesions. And last time we talked about the locations, and we said complete set of location descriptors consist of designation of right or left, laterality, by quadrant and clock face notations, preferably both. That is why they put it together. Okay, depth, which include anterior, middle, or posterior, on mammography only, this depth, and the distance from the nipple. On ultrasound, corresponding to the depth, we are saying what? What is a descriptor on ultrasound? Corresponding to the depth.
Distance from the skin.
Superficial or deep?
Okay, let us study about this. Go and see what is corresponding to the depth on mammography. Okay, the descriptor on ultrasound. Homework.
Inshallah.
Okay. Laterality indicate right or left. And you have to have correct labeling. Right, left, MLO, right, left, CC. Okay. Locations, quadrant, and clock face. Yes. Upper outer, upper inner, quadrant, lower inner, lower outer, quadrant, and the central area, retroareolar area, or retroareola representing the central area. And on ML also we can find the axillary tail indicate the upper outer quadrant locations. Okay. And these examples of quadrants, you can use a bisecting line from the nipple, separating the breast into upper and lower on MLO and into lateral and inner into the CC. And where is the lesion on this image, and where is the lesion in other examples? By quadrants. Okay. Here it is clearly seen the quadrants.
Yeah. The first one on the left side is lower inner. This is
lower inner, excellent. Lower inner, excellent. Even without doing this bisecting line, we can just judge where is the lesions. Yes, it is lower inner on MLO. It is down. It is the inferior part of the breast. So it is lower on the CC view at the inferior part of the image, which represents the inner or represent the medial aspect of the breast. So this is lower inner. What about but you forget to tell the left breast, which is most important.
Yes.
That we have laterality is important.
Yeah.
Left lower inner breast, and we should also think about the clockwise. Okay, what about the quadrant in the other example?
Right upper outer.
Right upper outer. Yes. So, yes, both are invasive ductal carcinoma, lower inner and upper outer. Okay. So we described this previously, the clock case. Okay. And we said it is different from right to left. And on the CC view, the breast is compressed from up to down. So the lower part is superimposed with the upper part. Yes? At the center, when we draw a line from the nipple in the CC view to the back, so we are talking about which hour, which clock? From the nipple going,
12 o'clock.
both in
12
the
and
left and in the right. When we in CC view, the line drawn from a nipple to the back, it will be
12 and 6.
12 and 6. It will be 12 and 6. It will be 12 and 6. And when we go lateral, it will be
1
now
and
this
5.
image, the image here is right or left?
Left.
This example of
left breast.
Yes, why you are hesitant? To hear?
No, I'm trying to concentrate about the clock.
What of, is it right or left to hear?
This is left breast.
It is a left breast. So left breast,
Yes.
when I go outer, it will be
Outer, it will be 12/6.
12/6 at the center. 12/6 at the center on the CC view. Then when I go out from 12, it will be
1
superimposed
with 5.
With 5. And then
Yes.
more outer, it will be
2 superimposed on 4.
2 on 4. And the outermost, it will be 3.
3.
It will be 3.
Yes.
So when I go medial, it will be after 12 immediately it will be
7 superimposed on 11.
11 and 7. Okay,
Yes.
and then
Medially 8 superimposed on 10.
Aywa, 8 on 10, and then extreme
medially
medial it will be
9.
It will be 9.
Yes.
So an MLO, I will superimposing the medial with lateral aspect of the breast. And at the middle, it will be the dissecting line from the nipple, it will be going through
3 and 9.
3 and 9. 3 and 9. And the uppermost, it will be central uppermost, it will be
2. It will be 2.
2 and 8.
2 or 12. 2 or 12. Central.
Central is 9.
No, 9. You said 9. It will be. You are superimposing the medial and lateral now with the highest point at the center. You see, at the center, highest point it will be 12, and lowest point it will be 6. And the 9 and 3 it will be superimposed. When you go up, then after 9 you have
2 and 10.
superimposed with 2. And then you have 11 superimposed with 1. Going down, we will have
4
8
and
superimposed with 4 and 7 superimposed with 5.
5, yeah.
Is it clear? But on the right side, the medial, it will be reverse for the left breast. The 11, 10, 11 on the right side, it will be outer instead of the clockwise. It is clockwise. Same for the both breast, clockwise. See? But on the right side, the outer side, it will be the inner for the left one. Now it is clear?
Yes, okay.
Okay.
Yes.
So regarding the depth, we have anterior, middle, and posterior on the CC view and on the MLO view. And this is the distance from the nipple. And they said it is the most consistent locations that can depend on. Okay, so regarding the approach, in a summary, approach to the evaluation of a mass on mammography include an assessment of shape, density. Okay, can I give chance for some of you to give me a summary before just I'll tell it you. Abir, are you there?
Yes, I'm here.
Huh?
Yes, I'm following.
Okay, give me summary.
Okay. Okay. First, description of morphology of the mass regarding the shape of the mass, the margins, and the density. Shape, either regular shapes like rounded or oval, or irregular.
Okay, instead of giving in this way, you can give it in another way to make it more of clinical significance. Okay? So, in which way?
Sorry, I didn't get your point.
Yes, you can tell. Yes, now we know that the mass can be described by the most important descriptors are with order of frequency is margin, then shape, then followed by density. And we will look for associated feature just to support the diagnosis. And definitely we have to describe the mass size and its locations. Yes, but okay. So when I'm going to talk about these descriptors, I have to join with BIRADS. Yeah, it will be more of clinical significance. I can say,
Okay. So regarding the shape of the mass, the regular shapes, only as a descriptor, it could be probably benign. So BIRAD 3. For the margins, we have the probably benign margins could be either circumscribed or obscured. The remaining ones, so it will be BIRAD 3. The remaining ones speculated margin by RAD5, microlobulation, and indistinct margins will be by RAD4.
When you talk about BIRAT 4, you have to say BIRAT 4A, B, C. It's good. Because definitely it will be different, صح?
Yeah, yes.
4B.
For the
4B.
microlobulated.
And for the
And
indistinct. Both are
Yes,
4B.
it's same.
Both are 4B,
Yes.
yes.
4B.
Yes.
This regarding the margin. For the density, either equal density, high density, or low density. For the high density, it's probably malignant. So it will be BIRAD for 4C also, I think. I'm not sure.
Yes, you are right. 70.
Yeah. For the equal density, also it could be probably malignant. It will be for 4C also.
What? For what? 4C what? You're talking about what?
For the equal density. I'm not sure for about the BIRAD of the equal density, but it's
Equal
probably
density.
malignant for.
It is
So it will
4,
be
but
BIRAD
4. For what?
Yeah, I'm not sure. I'm not sure for what, but it will be BIRAD 4.
Is it less than 10?
No. No.
So if it is not less than 10, it will be.
B.
It will be B.
For B.
Because
Yes.
definitely it will. It is not like high density BIRAD C. And if you remember, it is not less than 10. It was 22%. So it is B.
Okay. The low density, it is rare for breast cancer to be low density.
Yes, but it is not completely excluded.
Yes, so it's
We have
BIRAD
seen
3.
example of DCIS and invasive cancer also with low density. Yes, so we have to be cautious. If the lesion morphology is suspicious, we cannot say this is low density, ignore it. Okay?
Okay. For the density, also it could be a fat density, which is almost always benign.
Okay. Okay, nice.
This regarding the density. So the other descriptor, is the size also. We have finished the morphology, shape, size, shape, margins, and density. The other one is size of the lesion. Larger lesions. Maybe associated with malignant chance more than the smaller ones. But it's not a rule, yeah.
What? What did you say?
The size of the lesion. I have to determine the size of the lesion.
Yeah, we have to determine size because it will affect the type of management and predictor for the prognosis. For staging is important for staging. Staging and the staging it reflects the prognosis and as well is essential for selection of treatment type.
Yeah. The other descriptor is associated features, which could be calcifications, I have to describe the type of calcification as it will affect the BI-RAD of the lesion. For example, pleomorphic calcification, it will be BI-RAD 4. Linear branching calcification will be BI-RAD 4C.
And pleomorphic itself, if just I found the calcification, this is not the time for evaluation of calcification. But BI-RAD pleomorphic, do you know the grading of which? It will be BI-RAD. You know it?
4B.
Huh?
4B.
It is 4B. It is a 4B. Excellent. Okay.
The other associated features like skin thickening, skin edema, by the thickening of it can be appreciated by thickening of the Cooper ligaments.
Excellent.
Nipple retraction.
Excellent. Excellent. Excellent.
And lymphadenopathy.
Excellent. Excellent.
The last one of the descriptors is the location of the lesion. I have to determine the laterality of the lesion, either right or left breast.
Excellent.
And the location by the quadrants and the clockwise.
Excellent.
Location.
As well as
also according to the depth, either anterior, middle, or posterior. And the distance from the nipple also.
Excellent. 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 Well done.
Thank you,
Hint.
Dr. Bob.
Thank you for you. Hint.
Yes.
Just summarize what she said. More summary.
Okay. In order to describe a mass, we need to describe its shape, its margin, its density, associated features, its size, its location. Certain descriptors are towards benignity, and certain descriptors toward malignancy.
Excellent.
Regarding, okay, in more details regarding the shape, it's either round, oval, or irregular. Regarding the margin, a round and oval was most probably benign, and irregular is a malignant feature. Regarding the margin, it's either circumscribed or obscured towards benignity, or indistinct, or microlobular, or speculated. This is regarding the shape. The density is either low density, or equal density, or high density. Low density, very rare to be malignant. Equal or high density can be malignant. Or fat density, which is a benign feature, BI-RAD2. And then this is regarding the density and margin and shape. Regarding the size, it could be large or small size. I think there's no difference to be smaller or large regarding malignancy, and it could be either or. Regarding the location, we have to describe the location in terms of laterality, right or left breast, then the quadrant, using the two views, the MLO and the CC, and then the clock notification, and the depth, anterior, middle, or posterior, or the distance from the nipple.
Okay, thank you. Okay. Anyone who would like to summarize? I'll give chance for everyone. Just if you would like to revise for himself And for the
Yes,
rest?
I would like to summarize.
Uh-huh.
Regarding the shape, it will be rounded oval or rounded oval shape, circumscribed. Margin, it will be
Circumscribed, not the shape. Shape
sorry.
is either regular or irregular. Regular, round or oval, and regular are probably benign. Irregular is suspicious by RAD 4C. Okay, this is
Okay.
regarding the shape. Regarding the margin,
the margin, it will be in this obscured, indistinct margin, or microlobulated or speculated. The benignity, it will be indistinct margin, probably benign, and microlobulated and speculated toward the suspicious.
okay, let me correct you. We have the margins circumscribed, obscured, circumscribed, partially obscured. These are probably benign. You see, these are probably benign with the predictive value of cancer is less than 2%. Okay, while microlobulated, speculated, and indistinct, these are suspicious with varies positive predictive value. Least is microlobulated, it's 17, so it is by RAD 4B. Indistinct is by RAD 4B, but it is 44, more suspicious than the microlobulated. And the most suspicious is speculated. We said it is by RAD 5. Since there are very minimal benign lesion presenting as speculated. Whenever we find a speculated mass, the probability of malignancy is very high. This is regarding the margins, okay?
Yes, regarding the density, it will be high density, equal density, or low density. The low
What
density
is the definition of density? When we are talking about density, Ferris, we are talking about which type of mass? High or low equal. We are talking about a radiodense or radio-opaque mass. Okay?
Yes. Yes.
We have either radio-opaque mass and we have fat-containing mass. When we talk about high or low equal, we are talking about radio or radio-opaque mass. Okay?
Yes. It will be radio opaque or fat containing mass. Fat containing mass, it is benign by RAD2, and radio opaque, it will be a suspicious. Regarding associated features, skin thickening, nipple
Why
retraction.
it is suspicious, Tawali? Why you said it is suspicious? We said probability of malignancy, it depends. High density, the high density is by RAD 4.
Yes.
4B. 4C, I mean, 4C. It is 70%.
Yes.
And the equal density by RAD 4B.
Yes, 4B.
And this is very low. The low density is very low chance. And what is the definition? What is the difference in definition when we are talking about low, medium, and high?
X-ray attenuation.
For what?
And when you said high density, low density, and like this, would like to go through examples for that.
X-ray attenuation.
Huh?
X-ray attenuation that's equal to or less than or more than the expected volume.
Okay, excellent. Khadija?
Yeah. Yes, Dr. Rabab, it's me.
Okay, thank you.
Okay.
I have friend before from Nigeria.
Really? Nice.
Yes. I spent with her about 1 year or more.
Oh, that's really nice.
Yeah,
okay.
your voice is similar.
Oh. Yeah, highly expected. We're from the same place, so yeah.
Okay, okay,
Yeah,
continue.
thank you.
Okay, continue.
So if the extra attenuation is less than the equivalent of the fibroglandular tissue, this is low attenuation, low density. If it's
Okay.
equal to, this is iso, equal density, and if it's more than the extra attenuation is
So
more
the
than
descriptor now
attenuation
is iso
or hyper
equal
or equal.
because,
Yeah, sorry, equal.
iso is historical.
Okay.
In the previous descriptor it was iso. The
ISO.
current descriptor is equal.
Equal, okay.
Yeah,
Thank
you have to say equal. Okay.
Okay.
If you
okay.
said iso, it will be understandable, but they prefer to follow the new prescriptions.
Okay.
The new descriptor. I mean, sorry, the new descriptor, not prescription. Descriptor.
Equal.
Okay.
Low density, equal density, and hyper density.
Yeah, high density. Yeah.
High density.
Okay, no problem. No
Okay.
problem. Okay. Okay. So the approach is of the mass on evaluation of mass on mammography include assessment of shape, density, margin, size, presence of associated findings like calcifications, the shape of the mass that are circumscribed, maybe round or oval. Then if the lesion is circumscribed, you don't expect the shape, it will be irregular. So since the margins is circumscribed, the shape, it will be regular, either round or oval, and it will be predict for probably benign lesions. Circumscribe allows one to visualize the fine clear edge around the entire mass, or at least more than 75%. Often masses that are circumscribed may be overlapped by parenchyma. In some areas, these are described as obscured or partially circumscribed, and as you know, it should be covered by more than 25% to describe or classified as obscured. A microlobulated margins, non-circumscribed. For the three suspicious, microlobulated, indistinct, or speculated, we can collectively say these are non-circumscribed borders or irregular borders. Appear as the microlobulated represent a fine nodulation or undulation of the edge of the mass and imply suspicious features of malignancy. Okay, while benign lesions tend to be iso-dense or less dense than parenchyma, or it will have very circumscribed margins. Okay, while malignant masses are more often of greater density and have irregular shape, indistinct or micronodularity or speculated borders. Okay, masses for which any portion of the margin is non-circumscribed, whatever it is microlobulated, indistinct, or speculated, will be classified as suspicious, with varies positive Röntgen value as we described. The least is microlobulated and the most is speculated. Typically, benign masses para two circumscribed masses with microlobulations, fibroadenomas, and calcified cysts, masses of fat or mixed density, circumscribed masses corresponding to simple cyst in sonography. These are BI-RADS2 on mammography. Okay. We'll go through some of the examples. Yeah, I need volunteer. Quickly to finish all. We spent long time in the descriptors, so that everybody now he could remind or remember, he could remember all of the descriptors. Okay. I'll go one by one. Abir.
Welcome. Okay.
Describe what you have seen. Yes, what we have seen. What you have seen.
Rounded mass. With circumscribed margins.
Are you
Mixed
sure?
Density.
Yes, mixed density, agree.
Margins are speculated.
Yes, speculated. The margins are speculated. So you have relatively thick wall, opaque,
thick wall, yes, capsule
of speculated margin surrounding a central, well-defined fat density or fat containing mass. Just like that. What could it be? Outer is speculated, inner fat containing.
It's probably malignant by RAD5.
Okay. Nihal, are you there or left?
Yes.
Nihal?
أيوة معك دكتورة.
أهلين. What is this lesion?
No, this is the fat necrosis, I think.
This is the fat necrosis, yes. Why I select you? Because
yeah, I mentioned it before.
You got it. You got it.
Yeah.
This is the and what we have said, yeah, Abir.
Yes, doctor.
We state that any mixed or fat containing lesions, okay, is benign lesion.
I said probably malignant because of the speculations in the margin.
Yes, this is one of the mimicker. Because the speculation now, you see, it is a mass. This is a mass. We said if you have seen suspicious features with the fat, other than mass, it can be cancer. But if you have a mass and within the mass, you have a fat containing density, it will never be a cancer. You got it?
Yes, thank you.
Okay, so this is a fat necrosis. Okay, so rim of dense tissue having speculated margins surrounding a circumscribed fat containing mass. Looking for history of biopsy, surgery, trauma. You see the presumptive diagnosis will be all cyst or fat necrosis. Okay. Next. Now you know, يا جماعة. Ignore the location unless I'll ask you. Ignore size or location. Take the first descriptor, morphology and density, if there is associated features. Hint.
There is an oval circumscribed high density mass in the lower aspect, anterior 1/3, associated with lymphadenopathy. It is there is something, but I'm not sure. And the margin is yes circumscribed, but the anterior portion there is a little area which is indistinct.
So, if you are working, what is next? You are going to do it to make sure. Huh?
Spot view.
I want to do a compression magnification view.
Yes, do spot. Before a spot, this is the other view. You did not ask about the CC. What about the CC view?
So the margin here, the shape becomes irregular and the margin indistinct.
Yeah, and
even
you want to make sure. This is a compression. This is a spot. Now?
Yes. So the margin is indistinct.
Indistinct only?
And there is maybe even speculation.
Yeah, there is speculations. So you are dealing with.
Yes.
And now the lymph node is become significant. Even the lymph node is dense and irregular. So this is Bayrat
5.
Yes, yeah, in that way we'll take the and it was, you see, that it was infiltrating ductal carcinoma. It is Bayrat 5. Okay, next. Medina, she left?
I'm here.
This is your case.
Okay, this is a fat-containing lesion.
Excellent. Describe the margins.
Yes, it has a circumscribed margin.
Look carefully. Look carefully. Look at the margins. Fat containing mass. Excellent. Well done.
Yeah.
Full stop. But
yeah.
the margins.
The margins are. I think it is macrolobulated. So it is.
Yes, it is microlobulated. Excellent.
Yes.
Microlobulated.
Yes.
You put your glass.
Something like that. I pray, just pray.
Okay. Okay.
And it is fat containing. So most probably this is the hamartoma.
Okay. Okay. Can you see any opaque or mixed component?
Yes.
There are mixed component?
Yes, mixed component.
It is fat.
Yes.
So it is almost fat. I have seen, I agree with you. I have seen some little as if there are septum or something. But according to the SER, they describe it as just a fat without mix. They did not describe it as mixed. So I suspect that because of superimposed structures, that might appear from the behind, and the margins are microlobulated. But in spite of suspicious margins, since it is containing, the diagnosis is
almost always benign.
Presumptive diagnosis.
Yes, it is
They put it as a lipoma. This is a lesson
Uh-huh.
from being fat containing. Okay.
Okay. Mm-hmm.
Okay. Thank you. Suhair, are you there?
Yes, I'm here.
Heidi. Okay, wait. Heidi. Heidi left.
Yes, I'm here.
This is for you.
Okay. There is fat containing lesion, well defined.
Lesion or lesions?
Lesions, two lesions
Where?
overlapping. Retroareolar. Most probably oil cyst.
Okay. And what about the other side?
Other side. Where is- I think there is
Okay, smaller.
small.
Smaller in the contralateral. If you have seen multiple oil cysts in a young lady, what do you expect? Her breast, look for her breast. It's not sagging, it's not a sagging breast. It's not, yani it seemed to be well circled,
You mean
good shaped breast.
Yes, good shape, yes.
Yeah.
Augmentation. Augmentation surgery.
Okay, augmentation. Which type of augmentation?
بالinjection of fat. ما مذكرة اسمه
Yes,
بالضبط.
injection autologous fat filling. It is lipofilling. Lipofilling. Okay. So this a fat containing with thin rim of thin opaque rim representing pseudocapsules. Okay, since are multiple and bilateral, this is my patient. That is why I know her. She has history of lipofilling,
It is a complication of lipofilling or what?
Yeah, it is a complication of lipofilling.
Okay, very nice.
And even this lady, she presented later with rupture of this one fat and make a lot of inflammation in her breast and edema and this. This cyst is ruptured.
Excuse me, Dr. Rabab, regarding this image, in the right breast, there's associated lymphadenopathy.
But the lymph node,
axillary lymph.
Yeah, lymph node, this one, yani, we have seen only part of it, you see, and it doesn't show much suspicious features. In large lymph node, it can be just benign, can be reactive lymph node with inflammations. In fat necrosis and this inflammatory process, you might have a reactive lymph nodes. Okay, but even it is very limited image here, but it's good. You are a good observer. You are the good radiologist. Hannah.
Thank you, Doctor.
Hannah. Are you there or left? Dr. Hannah. He left. Khadija.
Yes, Dr. Rabab.
Yes, this is for you.
Okay, we have multiple
May you read the history? May you read the history?
60-year-old previous mammogram.
Make use of anything given to you.
Okay. This is a 60-year-old previous mammogram, was normal. What are the findings? We have bilateral, multiple, high density, circumscribed.
Excellent.
Lesions.
Okay.
Involving the whole breast, like anterior, middle, and posterior thirds involving the whole breast, Dr. Rabab.
Yes. So are multiple or more than multiple?
Multiple.
Numerable. Innumerable.
Innumerable, yeah, innumerable. This
Or
may be,
numerous. Or numerous.
Yes. This may be result of silicone injections. I don't know.
Excellent, well done. May represent the silicone injections.
Yeah, from
Yes,
previous,
since it is
they
it's
said the
seen in
previous
1 year.
was normal.
Interval. It can represent the silicone injection. Well done. But no history of silicone injection.
It may represent metastasis.
Excellent, well done. From where? Metastasis, yes. Like so
lung.
aggressive. This is very aggressive.
Yeah.
Melanoma?
Excellent.
Melanoma or lung?
Melanoma, yes. Yes, melanoma.
Yeah.
Or metastasis from other side, other primary. So differential, it can be metastasis from other primary. It is a melanoma metastasis or silicone injection. What could be? What could it be else? Differential diagnosis.
Could it be skin lesions or superimposed on the breast parenchyma, like neurofibromas, multiple neurofibromas?
But can you see any more superficial one? Yeah, it can sometimes simulate, but usually you will see one a little bit more peripheral. Yeah, one of the differential diagnoses. What else? It is a case of metastatic melanoma. You see, it can be multiple fibroadenomas, can be multiple cysts. Yeah.
Okay. Yes.
Very unlikely in 1 year to have multiple fibroadenoma like this. But it is in the differential diagnosis. Multiple cyst, it is in the differential diagnosis. Silicone granuloma, yes. Lymphoma, yes. And metastasis from other side. Thank you, Khadija.
Thank you, Dr. Rabab.
Okay. Hana, Dr. Hana left.
أهلا دكتور رباب كيف؟
هلا. This is for you. This is for you.
Okay. This is and well circumscribed lesion or mass.
Excellent.
Rounded or
excellent.
With high density relative to the breast parenchyma in the outer part of the breast.
Which breast? Which one?
This is right one.
Or facing to your right side. It will be
left one.
This is left.
I think right. Left one. Left.
You see the left, when you put your right hand,
yes.
The breast facing your right hand is left, and facing your left one is right.
Okay.
So
in
this is
left in CCU view.
Excellent.
There
so
is
your parad, it will be.
This is goes with benign lesion. There is an surrounding or
benign
there is a small.
You mean Bairatu?
Yes. In this case, I would like to do ultrasound to confirm it is cystic
You will
lesion
do-
or not.
Yes, طيب, before you are going to ultrasound, the ultrasound is either upgrade or downgrade. Okay?
Yes.
So it will
Yes.
not. So if you said BI-RADS 2, no need to go for ultrasound. So this is BI-RADS. We said circumscribe regular shape is BI-RADS 3 on mammography. It will be
Yes.
BI-RADS 2. If it will be BI-RADS 2 if ultrasound
upgraded,
that opaque
yes.
lesion is cyst, simple cyst.
Yes, yes,
In
exactly.
this case, we can say this is BI-RADS 2. Otherwise, it will be BI-RADS 3. Still, there are 2% or less than 2% probability of being malignant. Okay.
Yes, you're right. Okay.
Let me show you. This is the same patient. How you can explain for us this appearance?
Okay. This is the same patient at
Yes.
this, after what time, Yani?
Try to imagine what happened for this patient.
So
why we have
this
why we
the
have this
density.
appearance? Hmm?
Yeah, yeah. The density is mixed density, or fatty density, and there is an area of high density. With still well circumscribed margin. I will suspect it's
why it
fatty
changed?
growth.
Question. Why does it change? What happened? Make it like that. The participants start to disappear.
Yes.
They escape. Okay, can you look here?
Maybe if a rupture, but there is no area. Maybe, yeah. There is an low density surrounding low density.
What is
necrosis after biopsy was
yeah.
taken, maybe.
Yes.
This
this low density area.
Track of
the needle of biopsy.
Track of needle. So
okay, aspiration due to aspiration.
Yes,
yeah.
It was aspirated after you see, before aspirations, it was the whole opaque. When they aspirate the fluid within, we could see part of the cyst is not aspirated. That means it represents what? This is the cyst, this is a wall of the cyst, and this part of the wall is what?
Cystic lesion.
Nodular thickening. This is nodular thickening, which make it so downgrade or upgrade now?
Upgrade.
Upgrade to? Yes, it is upgrade. So the lesion, it has to be biopsy, not only aspirated. Yes. And what do you suspect in this case to be?
I suspect it to be malignant.
Yes, I see, but malignant, which type you suspect? Cyst? Contain papillary projections.
I can maybe it could be
yes, you are right.
Medullary.
Why medullary? Papillary, excellent. Papillary. I told you cyst with the papillary projection, and look for the ultrasound. Look for ultrasound, and if you look even for the wall, apart from this nodule, even the wall is not uniform, is asymmetric. And look here for this angular margin and this angular margin, and this is a nodule.
And
You
this
see within the cyst and
solid.
breaking even here, it is the wall. This is, I have shown to you their examples for the 1.4% of circumscribed lesions. And the outcome was intracystic papillary carcinoma. See?
Yes.
It is not my patient from the literature, but it was intracystic papillary carcinoma. Okay.
Yes. Yes.
So that I brought it as example for the circumscribed lesions. If you have a circumscribed lesion, we should not say خلاص. This is circumscribed.
Yes. Thank you.
No, thanks for my duty, dear. Okay. Who's available with us? Volunteer. I don't like to say by name. Otherwise, I'll find all will disappear. We want everybody to share us and all of us just to study and to learn.
Yes, Dr. Rabab, I'm here.
Excellent. Well done, Suhair. Huh? Continue.
There is a circumscribed mixed density containing fat density lesion with thin pseudocapsule at the upper inner quadrant. I think this most likely representing a hamartoma.
Okay. What else? What is
the differential including with this history including fat necrosis.
Yes, you have to make use of anything. Now you got it. Excellent. Why fat necrosis? The history, and even if you look for this, look at this ball, radiodense ball within the lesions. Look at it on CC view and on MLO view. It's settled down. It is settled down. It is moving. And this is characterizing the fat necrosis.
Oh, yes.
This ball, you see it here, and now it is settled down. Look at it. This is characteristic for fat necrosis.
Yes.
And see it here on ultrasound. You see, it is not related, is not fixed to the wall. It is floating. You see, floating ball. They call it floating ball. This is challenging case. I will leave it for who is interested. Who would like to share? Yalla ya shabab, let us continue to complete our cases. I spent long time selecting for you. Maidulin, where are you?
I'm going to take the case.
Okay, welcome.
This is a fat containing mass, well defined with popcorn calcification.
Where, Medina?
It is a bilateral.
You have bilateral popcorn. You have bilateral popcorn. If you have this bilateral popcorn, this is BI-RADS 2. But do you think this mammogram is BI-RADS 2? Look at it careful. And compare
global asymmetrical density with skin thickening on the left breast.
Yes, you have a skin thickening. So the left breast is edematous. What is the cause of that edema? And the global asymmetry. The global asymmetry, you see, due to the edema and the skin edema and trabeculations. So there is something going in the left, on the left side, make it edematous. Why it is edematous?
Is it a lesion in the upper quadrant? I think there is
what?
Some irregular density في upper quadrant.
Okay.
Can I see the CC view, please, and some classification? There is
Excellent, well done. Excellent, well done. You got it. Allah dropped. I don't know why. You see, it was there, but mistakenly, let me try to make it for you. I will make for you Zoom, but it was there. Okay, let me. I don't know. The spot.
We can zoom it from the screen, Dr. Rabab.
Huh?
We can zoom it in the screen.
You can zoom it?
Yes.
Yeah.
Okay, zoom.
Yes, there is suspicious classification here in the upper quadrant.
Okay. Is it clear now?
Yes.
Yes.
Is it clear?
Yeah.
Yes.
Then describe.
Oh, nice.
It is within a map.
There is an irregular high density lesion with overlying suspicious.
How you can describe the classifications?
It is linear branching classification.
Linear branching classification. The branching classification itself, or fine linear branching, is BIRAT 4C, and there is underlying high density mass. It is not a high density, it is equal density. That is
Yes,
why you
equal,
did not see,
but irregular. Yeah.
you did not, and indistinct, irregular and indistinct. So it is and we
BIRAT 5.
associated with edema. That is what BIRAT 5. See?
Yeah.
It was a BIRAT 5. Yeah. Okay.
Nice case.
Yes. That is this case. It was my case. See, from my cases, my interested cases, not from the literature. Okay. Who is the volunteer for the next case? Huh? Khadija, can you take this? Because you had taken the similar one. Are you there?
I can take it, Dr. Rawab.
Okay, take it.
طيب, there is multiple bilateral circumscribed high density lesions. Some of them with equal density and some of them lying on the skin.
Excellent.
Projecting outward.
Yeah.
This is most likely neurofibromatosis.
Yes. This is 45-year-old asymptomatic for routine screening. So, and now, you see, the lesions make it double nipple sign, you see, and here are clear. What is the significance for that? Significance for for those.
Neurofibromatosis in the breast.
Yes. They have increased risk for breast cancer.
Oh, yes. I forget, sorry.
Yeah, they have increased risk. Okay. Medina? Are you there? Suhair, Hind?
Yes, I will take answer here. I will take this case.
I speak with the phone. Okay.
There is a novel shape, partially obscured, high density mass at the upper outer quadrant of the left breast.
I think we have seen this case. We have seen it, but no problem. Continue. That is the only.
At the right breast.
And there is this, and these
Multiple bilateral, yes. Multiple equal density. There are multiple equal density.
Yes, so what
at
do you
the left
expect?
and the right.
Either differential diagnosis
include multiple multiple fiber adenomas. And it could be fiber adenomas. It could be suspicious mass on the left side with metastasis to the right side.
Although rare, but it can be.
Other differential include multiple cysts.
Yes, it is a multiple. Okay, so this is the list of differential diagnoses of masses based on their density. Fat containing mass equal density, the majority of breast lesions representing the equal density mass. And the high density are mostly malignancy, cyst, abscess, hematoma, phylloides. These are most differential diagnoses for high density lesions. Go through it. Okay, and what is going here? What are these? Multiple
hamartomas.
Excellent. Look the hamartomas. It depends on the amount, relations of the fat to fibroglandular component. This is mostly fatty, mixed. This is more glandular. And look for this, simulating even fat necrosis. This, you see, gland, more gland. And this, what, Medina? What you are saying?
I said the typical breast within breast appearance.
Typical what?
Breast within breast.
Yeah, typical breast within breast. Yeah, typical breast within breast. And look for this, this even look like an opaque mass. If you look for the periphery here, you see you will see fat density, and beyond the fat density, you will see the pseudocapsule. That is representing a fat containing mixed fat containing mass of hamartoma. And this we can answer without like that. Anyone can answer. Here the examples is
Lipoma. Just lipoma.
Excellent. Lipomas. These are large, you see, oval, circumscribed, fat containing, and with the thin pseudocapsules. Okay. Okay. And these
Galactocele.
Excellent. Well done. Well, why you said galactoceles?
Because of fat leveling.
Yeah, levels, fat fluid levels. And here you look mixed density. These are mixed density, and this is mixed density, and this is a fat density. Might be get infected, you see. And this is pure fat containing, but sometimes thick wall might related to the associated inflammation and these things. Okay, and this one. What about these lesions?
The intraductal secretions or
make use of what you have seen, what it is. And what about this area of distortion? And there is mixed density.
Fat containing, yeah. Fat containing. Fat necrosis. This could be fat necrosis.
If I'll tell you this patient have recent operation.
Oh, surgical changes.
So mixed density, it will be
hematoma.
Hematoma. Yes.
Yeah.
This is post-surgical or post-excision hematoma. And if you look, there is clip here. That is the clip, okay? And this is post-traumatic hematoma, okay? And this is another case of a hematoma, giving mixed density. Okay, and this is multiple all cysts, okay? And this is fat necrosis with the floating nodule or floating, I forget exactly the name for this floating. What is going on here? What are these lesions?
The lymph node.
Intramammary lymph nodes. Okay, just intramammary lymph node and leave it. It is a mixed density.
No,
typical, with typical characters or criteria. These are typical, just an oval circumscribed mixed density with central fatty hilum like this one. Okay, but what about this?
This is rounded with local central fatty, or local fatty central. This suspicious lymph node.
Okay, so these are pathological lymph nodes.
Yes.
These are pathological. And what about this?
This also pathological.
Yes. This is malignant because there is irregular mass here. I can see the malignancy and it's more rounded. But this is still are oval. So this I can say pathological. I could not see primary tumor. It still can be reactive. Okay, can be inflammatory. But this one is more suspicious, more rounded, and there is associated irregular mass. And this, you see, the spot magnification, this one, when do spot magnification, the fat density, it looks like a nodule at the periphery here, at the subcutaneous area. But the spot view is helping us to demonstrate the central fatty hilum. You see? And this is a mixed density after the compressions in the location of subcutaneous representing intramammary fat. This one, as I mentioned, it is metastatic breast cancer into intramammary lymph node, and this is the primary invasive cancer. And this enlarged lymph node examples, it was inflammatory. See, that was inflammatory. And even this is not a normal. This is also look pathological. It can be reactive lymph node. And I think this is for this. This one is for this one. Okay. These are examples. Just give me BI-RADS, even without descriptions. 1, 2, 3. Just BI-RADS.
Okay, the first one is I think it's BI-RAD 3, and the second one is BI-RAD 2.
Nihal?
أيوة نهال.
Nihal, first one this or this one?
This one.
This one left. This is BI-RAD
3.
Excellent. And this?
this is well circumscribed. I think it's BI-RADS 2. And the last one, BI-RADS.
Nihal,
أيوة.
sleepy, or you was sleeping since we start our lecture? Huh?
No, I'm not sleeping.
We said the only we have certain lesions to say this is BI-RADS 2 on mammography. Unless either the lesions is containing fat.
Okay, then both of them are BI-RADS 3.
If the lesion is opaque, I need to do ultrasound and to find it a simple cyst.
Okay, to
Correlated
downgrade it.
with ultrasound to say this, the mammographic lesion is ultrasound confirmed simple cyst, so this is BI-RADS 2. Otherwise, we have no BI-RADS 2.
Okay, BI-RADS 3 then. Okay,
So,
and the
we said when the circumscribed, okay, margins, regular shape, oval or circular, then it will be BI-RADS 3. The next step it will be
ultrasound.
So the three case are BI-RADS 3. The three, because all are circumscribed, but are hidings. See?
Yes.
But here I'm not going to take the high density. I'll go for probably benign. Or even if I upgrade it, I'll put it BI-RADS 4A. I'll not go to say this is, but I supposed to go for ultrasound.
Yes.
Because of high density, I'll not leave it. Okay. So these lesions confirmed to be fibroadenoma. While the third one, it was intracystic papillary carcinoma. You got the lesson from this?
Yes, sure.
We should not, it is high density. We cannot leave it even if it is circumscribed and regular shape. High density, we have to consider. We have to proceed and characterize it further.
All right.
I have a question. The skin in the first, I want to ask a question. The skin in the first image on the left side of the skin, at the site of the nipple, is it normal or thickened?
You see, this thickening, it depends. Sometimes their nipple, and if you look for this one, it looks the same. For young ladies, sometimes their skin is relatively thick, and sometimes there is some wrinkling of the areolar skin give apparent thickening. And most of the causes for the areolar skin thickening is periareolar ductal mastitis. Periductal mastitis in the retroareolar region. This is the most common cause. Then you have to look, definitely you have to work up and to make sure these are the causes, either normal or just periductal mastitis. Okay? And to exclude, and to compare with contralateral sites and with the clinical.
Okay.
But the lesions here, these are three similar lesions. Two are fibroadenomas, while the third one is intracystic papillary carcinoma. Okay, what about this one? Another circumscribed high dense lesion. What do you expect? Circumscribed, partially obscured, palpable. It was mucinous carcinoma. So one of the differential diagnoses of circumscribed lesions, mucinous. And this high dense circumscribed lesion, we said the cyst, one of the cysts the cysts in general are along with phylloides and with abscess are differential diagnosis of carcinoma regarding the high density masses. What are the special type of cyst do you expect in a differential diagnosis in an endemic areas?
Hydatid.
Yes, but I don't think this is not the case of hydatid. No, this is not the hydatid. This is not the hydatid one. This is
carcinoma.
Circumscribed. This is carcinoma. Look, it is complex cystic solid, so expected to be papillary. I don't remember, but intracystic papillary, yes. It is intracystic papillary high grade because this is the one, this is the hydatid. Also, if you look, it is circumscribed, oval circumscribed, high density mass, pathology was hydatid. Okay, here this.
في ultrasound للهيداتد؟
لا, no, there was no.
Okay.
What about this?
Speculated mass.
Yes, this is speculated. What is next? It's obviously speculated. I'm pulling tethering the underlying pectoralis muscle suspicious for invasions. And look here, more obviously seen infiltrations, and the spicules is not only shortly here. These are all spicules and infiltration going. Okay, it's extending longer. And the tethering and infiltrations of the pectoralis muscles. And this is the lesions on ultrasound. What is next?
Biopsy. For
what
biopsy.
is it? What is this? Yeah, hint.
Marker.
Yes, look at it here.
Yes.
This is the BB marker. So next is ultrasound and next is biopsy. Okay, ultrasound guided biopsy since it has been seen. And even look for the speculation, even on ultrasound, demonstrate the speculation. What about these lesions?
It's irregular and indistinct. Although
what about this? Hello?
Here it is circumscribed, but in the other view.
Circumscribed. So this part?
Obscured.
Obscured. And even here, this is a halo. You see, this is obscured. High density, circumscribed, partially obscured. You see, with a lucent halo. They did not give here a diagnosis, only descriptions. Okay. And what about this one?
The irregular lesion, irregular high density lesion with speculation towards the nipple.
Excellent, excellent. So
Look
look for ultrasound showing the speculation much more than on the mammography.
Yes.
Yes, irregular, indistinct, speculated mass. Okay. And this mass here, it is just an irregular mass. It will be Bharat 4 C. For C. You see, and even having indistinct margins. It will be Bharat 4C. Okay. And here.
Infected cyst.
Yeah.
Circumscribed obscured lesion.
I think you got sleeping. You are sleeping.
I think.
Yes. Yes. Irregular high dense lesion surrounding edema.
Yes. Indistinct, irregular. An ultrasound deeply hypoechoic like cystic. But look for the indistinct, even on ultrasound is indistinct.
Sequel, yes.
You see, indistinct, not sequel, it is not cystic. Simulating a cystic is deeply hypoechoic. It's a metastatic, metaplastic carcinoma, I think. It is, you see, this is this is the same pathology, but other lesions.
السكرين مشت مني.
Mammogram show indistinct oval hyperdense mass subariolar regions. Ultrasound angular hypoechoic mass subariolar regions. What suspicious lymph node in the right axilla, this one. And this one, the lesion, these lesions on mammography is not so impressive apart from the associated edema.
Yeah.
It is indistinct, but not so impressive as seen on ultrasound. Look at it at ultrasound. It is more suspicious on ultrasound than on mammography. It's microlobulated with angular margins, and look at it even on the PET. See, very high uptake. Yes. What are the most important mass descriptors?
I think the margins.
Margins, excellent. Then?
ما فهمت السؤال طبعا.
Then after the margins?
Density.
Density, yeah.
Density before the shape?
Shape, لا, margin, shape, and density.
Margin, shape, and density. These are the most important. Margin, shape, and density.
Yeah.
Then, what are other descriptors to complete the report?
Associated feature. Size and location.
Shape.
Okay.
And location.
Size, location, associated classification, associated features. So, just to complete the whole report. It's okay. So, what about this? I think it is the last. You have bilateral nodule. Can you see it?
Yes.
What is next?
Put view to show margin.
Excellent. I thought you will tell me ultrasound. So if you will go for ultrasound, you might not find any of these.
Yes.
Huh?
Yes.
You might not find the lesion itself.
Yeah, big breast, huge breast, small lesions, ISO or equal density. You see, it's not even, yani, the one on the left might be a little bit higher than the right one. So we have to go for the spot and see. You see, you see the left one, the denser one is demonstrating what? Indistinct margins, while that one is circumscribed. So the left one is suspicious.
Yes.
The patient have bilateral two small lesions. We should not say this is tiny things, just ignore it. We have to clarify. We have to make sure and to characterize these masses and to make sure about the morphology. Yes, we could not see much morphology or detailed morphology on the standard view. So, Sarah, someone raising his hand. Who is raising the hand? By mistake? No problem. It's okay. So the lesson from this is we should not ignore tiny things. We should not ignore further clarification and characterization. We have to be more precise. We have to give all women their rights, okay, and to examine them well and to make sure what is going on so as not to miss cancer. You see, if we pick cancer as smallest as this, we'll save their life.
كان عندي كيس زي دي يا دكتورة باب، كان عندها tiny dense area في الريترو اريولا، فلما عملنا سبوت فيو طلعت لنا هم multiple و suspicious. لما عملنا البيوبسي طلعت invasive ductal carcinoma كانت subcentimetric, the largest one subcentimetric.
Yeah, thank you very much.
Thank you for you.
الحمدلله.
جزاك الله خير دكتورة باب، وعافلينا يعني معذبينك معانا.
لا ولا يهمك. So in conclusion, mass margins and mass shape are the most important indicators, followed by mass density, and the contour or margin is the most discriminating morphological criteria between benign and malignant masses. Most circumscribed masses are benign, and while indistinct microlobulated or speculated are suspicious, require tissue sampling and having varies positive predictive value. As we described before, the maximum is 96 of speculated margins. However, in rare cases, certain benign lesions may appear in the form of speculated margin, and certain malignant lesion or lesion with risk of malignancy may appear as circumscribed masses, as we described previously. And give, can you tell me the differential diagnosis of this, just to remind ourselves for the 1.4%?
Papillary carcinoma,
Papillary
medullary carcinoma,
okay,
carcinoma,
mucinous medullary,
mucinous carcinoma,
mucinous,
Phylloid carcinoma,
phylloid,
metastasis,
phylloid, metastasis, high grade invasive ductal carcinoma. Excellent, excellent. Okay, breast mass density is significantly associated with malignancy. However, consistent measurement of mass density is challenging, as we described. So they suggest more use of mass density descriptor to improve its evaluation and to be the more consistent with the more consistent. The mass density, when they checked before in the previous many studies, they found that density is much less used than the morphology, margin and shape descriptors. So they recommend to be used in your reporting. Mass size is independent, significant predictor of malignancy, and I'm not sure about this. I just found in one study, but I know it is important for the selection of treatment and is predictor of prognosis. The mass should be measured and located, and mammographic assessment include comparison with previous mammography and the use of spot magnifications or spot compressions to allow for more precise analysis of shape, contour, and density of the mass. Thank you very much. Any questions? Any questions?
Thank you very much دكتورة باب، ربنا يجزيك خير إن شاء الله.